You sure you're ready?
Yes,
Go
sorry.
ahead.
Hello, everyone. Good afternoon and a good morning to all who are joining us from the Central Mountain and Pacific time zones. My name is Keisha Shropshire, and I'm the coordinator for this P2P workshop. Welcome to day 2 of our 3-day virtual workshop. If today is your first time joining us or you're returning from day 1, thank you for being here. We're looking forward to another productive discussion and event. We will do a quick review of the housekeeping items for today's meeting before we get started. Next slide. Oh, Catherine, I think we have the wrong slides.
Oh, these are the ones that Jen sent me.
Here we are.
You want to share your screen then if you have the.
I got them up now. Thank you.
All
So,
right.
well, all
So are
right.
you sharing your screen then?
No, they're on the screen.
Catherine,
Oh,
I think she switched the slide deck, but the audience is not seeing the switch slide deck. Let's pass the presenter role over to Keisha. And then when she shows whichever deck she wants, it'll show up for us. Or are we, which deck are we looking for, Keisha?
it should be 00 in front of it in the drop-down menu. So it's saying
That one's
00
speaker
dash.
guidance.
Oh, that's speaker guidance.
Yeah, I think we want guidance.
Can you all see my screen now?
Yes.
Okay, I'll proceed. Thank you. So let me just start over. So welcome again to day 2 of
Sorry about that.
NIH P2P workshop on nutrition as prevention for improved cancer health outcomes. Each day of the workshop, we will begin promptly at 12 p.m. Eastern Time. We have incorporated a few breaks throughout the workshop to give you 10 minutes to stand up, stretch, refuel, etc. as needed. During each break, you will see a countdown clock to inform you of the time to return and resume the event. Please note that today's workshop is being recorded and the recording will be available in about 1 month on the ODP webpage at preventionnih.gov/P2P nutrition cancer health. The chats will be saved as part of the public record and used for note-taking purposes. To access, hold on just 1 second. If you haven't already, please visit the workshop webpage. It will tell you everything you need to know about our workshop, and it's where you will also find the workshop agenda, independent panel bios, speaker bios, and abstracts, draft systematic evidence review, and the panel's draft report, which will be available in fall of 2022. We encourage you to share your questions and comments in the chat pod at any time during the presentation. Questions and comments will be taken via the WebEx chat pod. You may access the chat feature in the bottom right corner of the WebEx window located next to Participants Pod in the 3 dots. Once chat is selected, use the drop-down menu within the chat to select everyone. Please do not send private chats to the hosts or speakers that we can make sure your question is recorded. When asking questions, please state the presenter's name to identify which speakers your question is being directed to. If you prefer or have trouble with the chats, questions and comments may also be sent via email, or you may join the conversation on Twitter by tweeting your question using hashtag NIHP2P. All questions will be compiled and triaged and then shared with the workshop chair to be answered by the designated speaker during the discussion and Q&A session. In summary, there are 3 ways to submit questions and comments. Send a chat in WebEx to everyone, email NIHP2P at mail@nih.gov, tweet your question using hashtag NIHP2P. Should you experience any technical difficulties and need support, please use the WebEx chat pod to send a message to all panelists or email us at nihp2p@mail.nih.gov. Our WebEx host will assist you with troubleshooting and helping to resolve the issue. To access the closed captions for this workshop, click on the Multimedia Viewer feature at the bottom right corner of the WebEx window. To make content appear larger or smaller on your screen, use the plus and minus signs above the slides in your WebEx window. We invite you to review and provide feedback on the EPC's draft systematic evidence review report and the panel's draft report. The systematic review prepared by Minnesota Evidence-Based Practice Center is live and available for public review and comment until August the 23rd. You can access it via the ODP webpage link provided in the chat pod. The panel's draft report will summarize the workshop and provide recommendations for future research priorities and will be available in fall 2022 on the ODP website. Before I forget, please remember to fill out the post-workshop evaluation survey at the end of each workshop day. The survey is different on each day. A survey link will be posted in the chat pod, and each attendee will also receive an email from WebEx with the survey link. It should take you only 5 to 10 minutes. We would love to hear from you about how today's event goes. Your comments will help ODP improve the P2P program. I will now turn the workshop over to Dr. Bob Hyatt for the workshop overview, which includes a recap of day one and an introduction to today's agenda and objectives. Thank you.
Welcome to the second day, everybody. This is Bob Hyatt. I'm a professor of epidemiology and biostatistics at University of California in San Francisco, speaking to you from Berkeley, California, this morning for me. Yesterday we had a wonderful day filled with great presentations and lots of information. We started out with two keynotes, one from Dr. Stephen Clinton, which was on an overview of improving cancer outcomes through nutrition, and another presentation by Dr. Mary Platek on terminology and consistency in the use of nutrition-related terminology. Then we tackled the first two of our questions. We have really 6 questions. But the first two have subsections, and we dealt with the first sections of the first 2 research questions. These dealt with the impact of nutrition on outcomes when applied prior to treatment and after treatment. Prior to means between diagnosis and treatment, so not a long period of time. During treatment is self-explanatory. So we had a series of speakers on that and discussed several different aspects of that research. Of course, we started with a report from the Evidence-Based Practice Center at University of Minnesota, which revealed a very interesting lack of research in many of these areas, and especially lack of research in the United States. Much of the higher quality work was not done in the United States. And then in the afternoon, and later in the presentation, we had a panel led by Dr. Colleen Spies, in which we had speakers dealing with the questions of challenges and opportunities in this field. So it was a packed day. Lots of questions and information was shared. Today, we're going to tackle question 3 and continue to answer the other subsections of question 1 and 2. Each question will have several speaker presentations and a Q&A period afterwards, which I will lead. We'll first ask questions of the panelists, and then, as time allows, questions from participants. And we will be keeping track of your questions in the chat pod, and they'll be queued up so that I can present those when the time comes. So again, welcome to the session. This is the second of our 3 days, and I'll turn it back over to Keisha.
Thank you, Dr. Hyatt. Now I'd like to welcome Dr. Helen Parsons from Minnesota Evidence-Based Practice Center to share results of the Nutrition as Prevention for Improved Cancer Health Outcomes Systematic Evidence Review, key question 3. You may begin, Dr. Parsons.
Thank you so much, Keisha. And I'm pleased on behalf of the Minnesota Evidence-Based Practice Center to present an overview of the findings from our systematic review. And today, during this presentation, we'll be focusing on the studies that were identified for key question 3. Next slide, please.
I've made you presenter and you can
Oh,
advance.
I'm sorry. Thank you.
No problem. Sure.
All right. So as a brief review, key question 3 asked what evidence there are in adults with cancer who will be or are undergoing cancer treatment. What is the effect of nutrition interventions on symptoms that are associated with cancer treatment, such as fatigue, nausea and vomiting, appetite, physical and functional status, as well as quality of life? As a brief review, for those who weren't able to join us yesterday, we focused on studies of adults. The PICO criteria were the criteria that we evaluated for studies to include in the review. And so the population that was included were adults that were diagnosed with cancer at or after age 18 who had or were at risk for cancer-associated malnutrition. And just a note that at risk for malnutrition for the purpose of our review was based on the author definitions in the studies, because we recognize that there was a broad range of definitions for malnutrition, ranging from everything of everyone being who is diagnosed with cancer being considered at risk for malnutrition to using very detailed validated tools. For the interventions that were considered, we included interventions that were delivered under the supervision of a nutrition professional and included a wide range of interventions, including diet and nutrition therapy, the use of special diets, dietary supplements, total parenteral therapy, nutrition counseling, or a combination used within a single intervention. For the comparator, we included studies that deliver these interventions relative to a standard of care or relative to other nutrition interventions. For key question 3 specifically, our outcomes were slightly different than those presented for key question 1 and 2 yesterday, and focused on things including fatigue, nausea and vomiting, appetite, changes in physical or functional status, as well as quality of life. And the intervention timing included those that were delivered pre-cancer treatment. And just to clarify, this was from the time of diagnosis through the initiation of cancer therapy, not really those cancer prevention studies, as well as during cancer treatment for this key question. And we included interventions that were delivered across a wide variety of both inpatient and outpatient settings, including home-based, hospice, and telemedicine care. To briefly review the included nutrition interventions, we recognized during the conduct of the systematic review there was really no agreed upon classification system for these nutrition interventions. And so based on input from our experts, we classified these interventions based on the content and the intent of the intervention. And I'll just briefly review them. So nutrition counseling interventions were those that included an individualized assessment of education and counseling for a recommended diet. The use of dietary supplements included the use of products such as adding an arginine or a glutamine or fish oil. And it was meant to supplement the diet but not replace calories. The use of special diets included the use of defined nutrition plans, such as fasting or calorie restriction, the use of ketogenic or Mediterranean diets, or some other special diet. Studies focusing on the route or timing of nutrition interventions were those that really only tested the route, such as the use of an enteral feeding, or the timing where they varied up when the intervention was initiated or how long it was used for, but the contents between the intervention and the control group were really quite similar. For nutrition support interventions, those included the use of total parenteral nutrition or other oral nutrition supplements. And finally, there were multi-component interventions that studied a combination of these interventions. We identified the literature from the Ovid Medline, MBASE, and the Cochrane Register of Controlled Trials and focused on randomized controlled trials that had randomized at least 50 participants in order to identify the largest quantity of high quality literature in order to identify potential impacts for this review. The included studies were published between 2000 and May of 2021 and will be updated for our final report. For reviewers, we had 2 reviewers that looked at the titles and the abstracts, and those that were seen as potentially eligible for inclusion were then reviewed at full text. And for those that did eventually meet all the inclusion criteria, we extracted information on the study design, the participant characteristics, the interventions, and the outcomes. For a subset of studies where we found a concentration of literature, either within a nutrition intervention type or a cancer type, we conducted risk of bias, which allows us to evaluate the extent to which the design and the conduct of a study may have presented bias in the results. And for the outcomes that you'll see as we present, if you see that in the up arrow, it showed that the intervention was statistically significantly better than the comparison. If it was a down arrow, that it was worse, statistically significantly worse than the comparison, and side to side that there was no difference between the groups. And as you'll see, because there was such a wide heterogeneity among the intervention types that were studied, the comparison populations, as well as the outcomes and timing of these interventions, meta-analysis was not feasible for this review. So this slide shows an overview of all of the included studies from our review. And I will just highlight the box here that focuses on key question 3. And as you can see, the majority of studies that were evaluating the effect of nutrition interventions on symptoms really evaluated the use of things such as nutrition support, nutrition counseling, and the use of special diets and other studies of dietary supplements, and those multi-component interventions were slightly less common. Just in contrast to some of the questions for key question 1 and key question 2 that were reviewed yesterday, you'll see that for studies focused on the use of symptoms, they were more commonly focusing on special diets, which were less commonly seen in those key question 1 and 2 studies. All right, so let's focus in on the results for key question 3. So similar to what we presented yesterday for key question 1 and 2, you can again see for nutrition interventions that were examining symptoms, they again were really concentrated among individuals who were diagnosed with gastrointestinal cancer. Additionally, we can see that the majority of studies in this area were high risk of bias, which indicated that overall they had lower study quality. The types of studies that were included that evaluated the effect of nutrition interventions on symptoms were focused both in the inpatient as well as the outpatient setting. Not surprisingly, many of the individuals who were studied were receiving multiple therapies, so they may have been receiving surgery and chemotherapy or surgery and radiation. And the second most common type of treatment type was chemotherapy alone. However, many of these studies did not use established screening tools to quantify malnourishment. Overall, the individuals that were prescribing or delivering the intervention were most commonly dietitians or nutritionists, but just as commonly, this information was not reported within the study. For route of administration, most of these interventions were delivered orally, followed by enteral administration. And again, similar to the studies for key question 1 and 2, most of these studies were conducted either in Europe or Asia, with very few of them studied and published within North America. In terms of the outcomes that were evaluated, you can see here the type of outcome that was evaluated in the study by the type of nutrition intervention. And as you can see in the third column, quality of life was really the most commonly studied outcome, which is not necessarily surprising because that tends to be something that's easier to quantify and collect, whereas treatment tolerance and symptoms, as well as functional status, while they were studied, were far less common in terms of their evaluation across this literature. Okay, so now I'd like to go in and focus a bit more in those low and medium risk of bias studies that indicated a higher quality study design. So among the studies for dietary supplements, we had 2 studies that were either rated as a low or medium risk of bias. And the first looked at probiotics and use of omega-3 fatty acids for a number of weeks, for up to 8 weeks versus a placebo. And they studied the impact on quality of life and symptoms and showed somewhat of an improvement relative to the control group. A second study, which was slightly larger, looked at the use of triglyceride and protein-enriched enteral nutrition versus standard enteral nutrition and showed no impact overall on symptoms. If we then move on to the studies that were rated as low or medium risk of bias amongst the use of nutrition support, which included oral nutrition supplements, we identified 4 studies that were low or medium risk of bias. And again, you can notice some fairly heterogeneous types of interventions, as well as the setting in which they were delivered. So for the first study, it was a larger, or actually the largest of the 4, delivered oral nutrition supplements with dietary advice versus dietary advice alone, and showed an overall improvement in chemotherapy, modifications, delays, dose reductions, and terminations, as well as an improvement in symptoms. A second study looked at overall the use of preoperative carbohydrate supplements versus fasting preoperatively and showed some mixed results on symptoms and functional status. The third study, again, this was in an inpatient setting, looked at the use of postoperative enteral and parenteral nutrition versus postoperative enteral nutrition alone, but was unable to determine if there was an overall difference in quality of life. And finally, the fourth study looked at overall use of oral nutrition supplements plus dietary advice versus dietary advice alone, showing overall no significant difference in either quality of life or functional status. And so overall, you can see here that there's a wide variety in terms of the types of interventions, the outcomes that were evaluated, the duration, as well as being delivered either in an inpatient versus an outpatient setting. Overall, from these studies, we identified that the most common types of interventions that focused on the evaluation of symptoms looked at the use of nutrition counseling, dietary supplements, special diets, the evaluation of the route or timing of nutrition interventions, as well as nutrition support. They were predominantly focusing on gastrointestinal and to some extent head and neck cancers. And for the symptom-based evaluations, they were looking both at the inpatient, surgical, as well as outpatient settings. However, when we did assess a subset of these studies where there was a concentration of literature, we found that the majority were rated as high risk of bias, which indicated overall poor study quality. Among those studies where we did find low and medium risk of bias, where the studies were rated as low and medium risk of bias, overall there were more mixed results on the effect of nutrition interventions, and we saw that they evaluated and examined different types of outcomes. Across all of these studies, there was high heterogeneity in terms of the populations that they enrolled, the types of interventions that they were evaluating, and the outcomes. So even among things that, for example, they may have studied quality of life, we saw significant variation in terms of when it was evaluated, how they were defined, the tools that were used to examine these outcomes. So I think that overall made it much more challenging for our group to do meta-analyses and ultimately made it infeasible. Going forward, there's a number of opportunities. As you can see from the highly heterogeneous type of interventions that examined the impact of nutrition interventions on symptoms, we have this broad and wide range of potential interventions that could be used. And overall, there's an opportunity to create a clearer conceptual framework for how these interventions may potentially influence overall outcomes that are of high interest to both the clinical and the patient populations. Again, within this literature, similar to our literature for key question 1 and 2, the current interventions really focus on those gastrointestinal cancers. So there's some opportunities to go beyond these populations and think about opportunities to test interventions where there may be of the greatest need, potentially the highest impact on symptoms or the potential for improved outcomes. Overall, there was also improved opportunities to improve the methodological rigor. As we saw, most of these studies were rated as high risk of bias. And really, there was an opportunity to identify more consistent and transparent reporting. Oftentimes, our group really had a challenging time identifying exactly what was done and by whom and when it was collected. So as a result, this consistent and transparent use of validated tools for assessing both malnutrition as well as study outcomes will be key. If you'd like any more information about key question 3, we encourage you to go to access the draft report, which is now available on the NIH website and is open for a 4-week public comment period at the website on this slide. Thanks for the opportunity to present our results.
Thank you, Dr. Parsons. We appreciate that summary. Let's welcome Dr. Ron Levin to present on cancer treatment side effects and nutrition impact symptoms. Are oncology patients receiving adequate nutrition care? Greetings, Dr. Levin. You now have the floor.
Hi, my name is Ron Levin. I'm a registered dietitian nutritionist and board certified in oncology nutrition. Thank you for the opportunity to present here today. I'm going to be addressing the question, are oncology patients receiving adequate nutrition care? And I will be discussing current access to outpatient oncology nutrition in the United States, and also speaking about how registered dietitians use a technique called medical nutrition therapy to help manage treatment side effects and nutrition impact symptoms. Please advance the slide. In terms of disclosures, I have only one disclosure. I'm a consultant on the NutriCare study, which is a medically tailored meal intervention among patients with lung cancer that is currently underway. Next slide, please. It's a fact that access to nutrition care in outpatient cancer centers remains inadequate across the United States. And even though it's well established that nutrition has a profound impact on cancer treatment and survivorship, most cancer patients have limited or no access to nutrition services provided by registered dietitian nutritionists. There are knowledge gaps that, if addressed, will help to change the way nutrition care is or is not provided at cancer centers. The areas of research that are most needed are to assess the effectiveness of nutrition intervention, to assess the cost effectiveness of nutrition care, to explore the implications of funding access to care, as well as help to support to develop guidelines that recommend nutrition or provide nutrition intervention. Next slide, please. Nutrition is important throughout the cancer continuum. We've been hearing that yesterday and probably through the rest of this conference. Today, I'm going to be primarily focusing on undernutrition in the oncology patient during active cancer treatment. As we've already heard this week, malnutrition is prevalent among oncology patients, with as many as 80% of cancer patients being at risk for developing malnutrition, depending on the cancer type, the stage of disease, as well as the modality of treatment. Most cancer patients will experience alterations in their nutritional status, and some of those will progress to frank malnutrition. Patients with the highest risk of malnutrition include cancer of the head and neck, pancreatic, gastroesophageal, duodenal, other GI tract cancers, lung, cervical, and ovarian cancers. The cancer itself may impair appetite, cause metabolic derangements, and may alter the ability to consume, digest, or absorb nutrients. Patients with late-stage disease are more likely to present with and develop malnutrition than patients with early-stage disease. And treatment modalities, including surgery, chemotherapy, radiation treatment, biotherapy, and immunotherapy, can each have a direct and indirect effect on nutritional status. Next slide, please. Unintentional weight loss is a known negative prognostic indicator, and both percent weight loss and BMI predicts survival independently of conventional prognostic factors. The success of anti-cancer therapy is affected by the patient's nutritional status before and during treatment. Patients with a decline in nutritional status and malnourishment are more likely to experience treatment toxicities, and this has been demonstrated in many cancer types and treatment regimens. Nutritional decline can impose treatment breaks, treatment dose reductions, and ultimately decrease survival. And this came up during the discussion yesterday on how best to capture the benefits of nutrition intervention. And I think one area that might be an area or an opportunity for research is looking at how nutrition can support treatment tolerance as well as completion of treatment. And so if you think about that, treatment, of course, is a discrete time period, and the effect is relevant to many different cancer types. So although a lot of the research that has been beneficial for documenting nutrition or nutrition services have been basically head and neck and GI cancers or pancreatic cancers. And so in this situation, actually, this includes a large number of different cancer types, including breast, renal, lung, colorectal cancer, and others. So this might be an opportunity. At its most severe, patients who are malnourished have a 2 to 5-fold higher risk of dying compared to patients with little or no evidence of malnutrition, as seen in both short and long-term follow-up studies. And I guess in the back of my mind, I'm wondering, is part of this risk due to incomplete or interrupted cancer treatment? What are these people dying from? And so both a low BMI and high BMI are associated with shorter survival, and special notation of obese patients experiencing sarcopenic weight loss. Sarcopenic obesity has been found to be related to even worse outcomes. And this is special notation from the dietitian perspective, because oftentimes obese patients will even be fostering weight loss early in their cancer journey. And this is something that the dietitians look to identify and also to intervene. And a lot of times the patients will tell you, oh, my doctor told me to lose 20 pounds. And of course, the dietitian says, well, which doctor told you to do that? Because I doubt it was your oncologist. Also, as we look at costs of care, malnutrition increases the cost of care for cancer patients, including longer hospital stays and cost of treatment requiring to manage complications. The presence of nutrition impact symptoms influences nutritional status. Nutrition impact symptoms are the side effects caused by the cancer itself and/or oncology therapy, and are defined as any barrier to intake, digestion, absorption, or utilization of nutrients. Next slide, please. 84% of cancer patients experience one or more nutrition impact symptom during their treatment, and often patients are dealing with more than one nutrition impact symptom at a time. Nutrition impact symptoms can develop and change rapidly during therapy and need to be addressed at each patient contact. Nutrition documentation from the dietitian includes presence as well as absence of symptoms, and may include a grading of severity. Each barrier may represent a challenge so different or so extreme in nature from a patient's usual experience that it overwhelms people's ability to cope or manage from the situation. So for example, people may have a good understanding of how to manage occasional bouts of self-limiting nausea, vomiting, or diarrhea, but the severity of the nutrition impact symptom, as well as the length of the time that it can occur, for example, people can have diarrhea for 6 weeks straight, is unmanageable without professional intervention. This list represents only a brief overview of some of the most common nutrition impact symptoms, including constipation, anorexia, and anorexia is seen in about half of cancer patients at the time of diagnosis and persists throughout cancer therapy. Nausea and vomiting, gas and bloating, reflux, indigestion, early satiety. Next slide, please. Additionally, diarrhea, alteration in taste and smell. And again, this is the type of thing that's very unusual for people to experience, so they oftentimes don't have an idea or a framework of how to get around this or how to manage it. And just an example, metallic taste can occur with chemotherapy treatment. From the cancer itself, people can super taste salt, super taste sweet, or have a blunting or absence of taste described as patients as though they're trying to eat cardboard or sawdust. Additionally, mucositis, dysphagia, xerostomia, or dry mouth, which can be very severe, impacting not just eating, chewing, and swallowing, but also talking and also sleeping. Next slide, please. The oncology dietitian intervention addresses the modifiable aspects of nutrition. And several years ago, Furon described that in pre-cachexia and cachexia states that there should be efforts made to address these modifiable aspects, including nutrition and physical activity. And even went forward to quantify that about 40% of the negative effect of early cachexia could be ameliorated. And that in this situation, early intervention was a key feature to management. And also yesterday we were talking about the question of, was there a nutrition benefit in advanced cancer? And I wanted to emphasize that the goals are different, just like treatment goals are different between early cancers and advanced cancers. And instead of improving quality of or nutritional status in the setting of a refractory cachexia, the actual outcome goal at that time may just be to maintain function, protect quality of life, and improve palliation. Nutrition intervention includes providing clear instructions to manage these nutrition impact symptoms, as I was just presenting. Also evaluating actual intake, quantitative and qualitative in comparison with assessed needs, and providing instruction on timing, frequency, food consistency, and nutritional density of food and liquid. And of course, these things are the modifiable aspects, right? These are teachable aspects that patients and families can take action to change what is happening in terms of their quantitative and qualitative diet. We also address surmountable barriers such as food insecurity, as well as access to oral nutritional supplementation or tube feeding supplies, access to a durable medical pharmacy. Counseling and motivational interviewing focused on stabilization of weight loss or weight gain, as well as the maintenance and preservation of lean body mass. Management of diet related to comorbidities, such as many patients come in with diabetes, many patients experience renal failure during chemotherapy, Crohn's disease, exocrine pancreatic insufficiency. Education regarding prevention of foodborne illness is required during alterations in immune function, as well as specific nutrient supplementation or replacement to address increased utilization or deficiencies. The specialized oncology nutrition skill set also includes expertise in initiation and management of tube feeding and TPN nutrition support modalities, wound healing, pre and post-surgical nutrition optimization, prehabilitation or rehabilitation within the framework, digestion and nutrient use in an altered or shortened gut, as well as evaluation and counseling regarding the appropriate use of complementary strategies, which includes prevention of fraudulent schemes. Next slide, please. Medical nutrition therapy is a technique that's provided by registered dietitian nutritionists, and it's a specific application of something called the nutrition care process, which is used in clinical settings, and it focuses on the management of diseases and involves nutrition screening, assessment, something called nutrition diagnosis, intervention, as well as monitoring of nutrition goals and adjustment of the plan. It is a framework that provides standardization, quantification, and codification of dietitian tasks and interventions. It is already available in most EMRs, and it is the basis for documenting malnutrition in the hospital setting. And it was specifically created to be utilized for research purposes. So I just want to make sure everybody's aware of that there are these this method that's already available that might be useful in terms of research as we're talking about, the information isn't being collected of who's doing it or what are they doing in terms of what techniques are they using in terms of their intervention. Medical nutrition therapy is the translation of evidence-based nutrition and application of current available guidelines into patient interventions to modify nutritional intake, modify the food, the diet, the lifestyle behaviors. And please note that if there is evidence for any of the strategies that we've been discussing, low carb, high calorie, high protein, ketogenic, intermittent fasting, fish oil, whatever, Mediterranean diet, the dietitian is the person who will translate that evidence into the practical and actionable instructions for patients. So based on what the guidelines, what the evidence shows us into what the guidelines recommend for care, the dietitian is the one that can help present that and help the patient to be compliant. This individualized in-depth approach has been shown to be effective in reducing cost and improving outcomes in several disease states. And I just wanted to mention that the nutrition assessment includes many of the same characteristics as other disciplines assessments, but also includes a detailed history of dietary practices, which is often completely overlooked or ignored in other assessments. And to address the question that came up yesterday regarding weight change in the setting of fluid overload, edema, or ascites, in part of the nutrition assessment is something called the nutrition focused physical examination, which takes that into account. Next slide, please. Individualized nutrition assessment and provision of evidence-based nutrition education should be part of a routine oncology survivorship. The stress of a cancer diagnosis motivates many patients and families to seek information. We're all familiar with that. Cancer patient survivors and their families, however, are vulnerable to fraudulent recommendations, diet practices, and websites which hawk things like cancer cures. If access to evidence-based nutrition is not available, where do the patients get their information? If it's not available at the cancer center, of course, they turn to families and friends, the health food store clerk, they turn to the internet, they turn to unlicensed, uncredentialed health coaches. In a recent study by Johnson, two cancer patient experts reviewed 50 of the most popular social media articles on each of the 4 most common cancers. And out of 200 articles, 32% contain misinformation and 30% contain harmful information. And not surprisingly, the median number of engagements for the harmful information was statistically significantly greater than for the safe articles. So this information is over, and dietitians are constantly besieged by questions from patients which are coming from a misguided background of information. In 2006, the Institute of Medicine report, Lost in Transition, came out, and it did lead to a requirement for something called the Survivorship Care Plan, which is that every cancer patient at the end of their treatment receives recommendations for protecting their health in the future. It does include nutrition risk information or nutrition risk reduction. But the de facto application is that because there isn't enough nutrition support available at the clinics, the de facto application of this recommendation is led to just generic templates, which are applied en masse. So basically just like a generic statement of eat healthy, which isn't very helpful. It is documented that dietary patterns are now one of the few modifiable factors that can prevent or delay long-term comorbidities experienced by cancer survivors. Yet surprisingly, many cancer survivors eat poorer quality diets than the general population. Combine this information with a recent study of the general population that documented that 85% of Americans favorably misjudge the quality of their diet. So again, nutrition education should be part of routine patient care, but also survivorship. As you can just see, there's so many different issues. Next slide, please. The key takeaways regarding the oncology patient nutrition segment here is that malnourishment is a negative prognostic indicator for treatment completion and for recurrence risk. Patients with cancer are one of the largest patient groups diagnosed with malnutrition. A portion of patient death is attributable to malnutrition rather than the malignancy itself. All cancer patients may experience altered nutritional status at some point in their treatment and survivorship, and early intervention is key because mild or moderate nutritional deficits may be reversible with nutrition intervention. However, severe nutritional deficits are generally not reversible, possibly can be stabilized, and that access to evidence-based nutrition information is a basic need across the continuum of care, which is cancer prevention, cancer treatment, and cancer survivorship. Next slide, please. These are a few of the oncology organizations that have some level of guidance or recommendation, or at least a statement that has something to do with oncology nutrition care. And as we've been discussing previously, the U.S. lags behind in guidelines for patient care. First, some of these are problematic. Many of the guidelines include minimal mention of oncology nutrition care, offering only comments such as refer to nutrition, refer to nutrition services, refer to a registered dietitian without guidance on who that is, where they are, when it would be, or how often. And second, many of the guidelines leave the onus of obtaining the nutrition care upon the patient. So the clinic will write the referral and then send them on their way. And the failure of such a guideline is that the referral outside of the cancer center setting, and maybe that's to a hospital outpatient center, maybe it's to an independent practitioner in the community, and maybe it is to some kind of a health coach. But there's difficulty in locating appropriate services. There's a delay in obtaining services, and the out-of-pocket costs that may be, may not, or may be coming from the patient may just be exorbitant for what the patient can afford. Next patient. I'm sorry, next slide, please. Many of the guidelines recommend general nutrition care, leaving out specific direction on how this is going to be accomplished. And I have in here the example from ASCO. It's a great start, but it needs additional information. And basically, it's just saying to refer. One example of an organization with clear and specific guidelines is the Clinical Oncology Society of Australia, the COSA guidelines. Which the evidence-based practice guidelines for head and neck, just as an example, outlines the frequency of nutrition care. And it states patients should be seen weekly by a dietitian during radiotherapy. Patients should receive minimum of every 2-week follow-up by a dietitian for at least 6 weeks post-treatment, and that patients should be reviewed by a dietitian as required for up to 6 months post-treatment, and then as long as they require management of chronic toxicities, additional post-treatment weight loss, and resolution of feeding tube utilization. So that's actually encompassing the real situation of what patients are experiencing. So I think that's an excellent example of a guideline that would be very effective. And the most comprehensive guidelines so far across the board are the ESPEN guidelines on nutrition in cancer patients, which include screening for malnutrition, identifying the signs and symptoms of anorexia, cachexia, and sarcopenia as early as possible, assessing nutritional status, providing multimodal care, including nutritional counseling, and lastly, ongoing rescreening and reassessment throughout treatment. Next slide, please. Access to outpatient nutrition care. About 85% of patients in the United States are treated at the local community cancer centers. So where do we stand in terms of access at the community cancer center? ACCC did a study surveying 174 community cancer centers and documented that 57% of cancer centers reported needing more staff and concluded there's a lack of sufficient staffing, reimbursement, and budget to provide comprehensive care across the United States, and need to estimate the cost. I think this is important for providing these essential services, and need to calculate the cost of services not currently reimbursed to develop uniform strategies for payment reform. Next slide, please. Many of the guidelines, oops, I think you skipped ahead there. Okay, no, sorry. Okay, that's right. No, go ahead. Demonstration of outcomes. So next slide. Sorry about that. Okay. So what is reimbursed by Medicare and Medicaid insurance? So inpatient care is covered as part of hospital services, but many of the screening protocols don't even trigger for nutrition to be seen, or nutrition to see patients even diagnosed with high-risk malnutrition unless they've been hospitalized for at least 5 days. Patients who receive tube feeding may receive services through a durable medical pharmacy if they have medical insurance. Medicare Part B only pays for dietitian services for diabetes, non-dialysis kidney disease, and post-kidney transplant. Medicaid is very independent. Sometimes we consider patients to be lucky if they have a comorbidity such as diabetes and obesity, because sometimes we can get that covered. And then some evidence that medical nutrition therapy in specific disease states improve outcomes. So we do have proof that specific disease states improves outcomes. We just don't have a lot in terms of oncology as a whole. We do have some evidence of cost savings, and of course the systematic reviews that are coming out might be helpful. Next slide, please. In the survey by Trujillo that was discussed yesterday, we found that the ratio of cancer patients in the NCI designated centers is 2,308 patients for every 1 dietitian. In this study, the conclusion was that the majority of cancer centers don't bother to bill because it's not reimbursed. And the conclusion was that the fundamental issue regarding the lack of dietitians available at cancer centers was the lack of reimbursement for care. Next slide, please. And in the current system, it's a setup for reactive care. We talked about that a little bit yesterday, that organizations that follow the current guidelines create a crash and burn cycle of late referrals to nutrition care, where the medical team does not refer until malnutrition is obvious and decline is progressive. And as it happens, nutritional intervention is also less effective in that setting. So continuing the cycle, which reinforces the belief that obtaining nutrition care was difficult, the patient did not benefit much from the intervention. And this whole system requires the paradigm shift from the old paradigm of expecting patients to experience malnutrition and allowing it to happen to the new paradigm of one of active intervention and support of nutrition. Next slide, please. I just wanted to mention that the oncology nutrition competency is supported by the Academy of Nutrition and Dietetics and fostered by the Oncology Nutrition Dietetic Practice Group, which created the board certification through the Commission on Dietetic Registration. And there are standards of practice. There are there's an evidence analysis library. There are also multiple publications and ongoing educational training materials to help expand nutrition practice in oncology specific areas. And if there is an expansion of nutrition services for oncology patients, there are mechanisms in place to upskill the 109,000 registered dietitians currently in practice. Next slide, please. And this slide just describes the goals set forth by the ONDPG and the Academy of Nutrition and Dietetics aligns with this P2P workshop, starting with the evidence, flowing into clinical practice, acknowledging the relationship between policy and advocacy, and then finally inclusion of nutrition as part of the fiscally responsible oncology care model. And then lastly, next slide, please. The areas of research summarized very similar to what other people have been recommending. But the last bullet point, which is oncology nutrition workforce needs to have benchmarking completed to better describe how many oncology registered dietitians would be needed to provide adequate care over the cancer continuum if there was appropriate funding. And just as a note in my own practice that I have personally found that a ratio of about 1 dietitian to 400 patients allows for all of the services that are recommended in the best clinical guidelines. Next slide, please. And then these are my final key recommendations, but basically, obviously, designing clinical studies very specific that will, using standardized taxon language for nutritional interventions to capture outcomes in oncology patients, convene an interdisciplinary working group to develop a consensus on standard definitions of best practices, as well as determine what it will take to implement health insurance coverage and reimbursement for nutrition services. Thank you so much for your attention.
Thank you, Dr. Levain, for that very fascinating presentation. Our next scheduled presenter, Dr. Declan Walsh, who is slated to speak about management of symptoms in cancer patients, is unavailable. So we're going to take a 20-minute break now and then continue with the agenda as scheduled. So we will return at 1:05 p.m. Eastern Time. See you then.
Great, thanks.
Hello, welcome back, everyone. Good afternoon and good morning to everyone joining us from the Pacific time zones. We hope you had some time to refresh and you're ready to listen to our last speaker for this key question 3. Dr. Liz Eisenring will discuss integrated models of care, Australian examples. You may begin, Dr. Eisenring.
Thank you very much and welcome, everyone. So yes, I'm very excited about the opportunity to share with you some of the different models of care, integrated care that we have in Australia. I have no conflicts of interest, but I would like to acknowledge all the amazing dietitians and different disciplines that have contributed to the amount of work that I will be highlighting. So from our most recent data of surveys of different cancer organisations within Australia was actually conducted only a couple of years ago. It was just pre-COVID, and over about 260 different cancer organisations within Australia were surveyed. And what we found was that, almost 3/4 did provide some sort of support and intervention to people impacted by cancer. Mostly, as we can imagine, it was a combination of acute care with some sort of outpatient setting, some actually within the home and some via telehealth, which of course has only increased during COVID times. What we do know is that most of the common support services, and I'm talking about all different types of tumour streams, psychological support, self-care. We know that exercise and nutrition is also some of the big support areas, and also lymphedema management. Some of the key things that come out, and I know they're not unique to Australia, but that, there is some really excellent care, but we still kind of work in silos and have a lot of specialist care. And here I'll probably share one of the comments from one of my patients who spoke about, amazing care. All the support staff were amazing. However, she felt like she was spat out of a very complicated system that she didn't understand and had to pull her health and her life back together again. So I think that's a really important part to remember as we do all this. So I've been very fortunate to be involved in the development of some of the evidence-based guidelines that we've done in Australia, starting back from my PhD over 20 years ago in patients receiving radiation therapy to the head and neck and gastro areas. And then more recently, head and neck guidelines, we've done gastro guidelines, lung cancer guidelines, all different sorts of models of care. So I'm happy to share some of those with you now. And I think like anywhere in the world, we've got some exceptional and really, I think, integrated care that's working really well, and I'll share that. But like anything else, we also have pockets where people can also absolutely improve. So most of them will follow the format that the RDs will be familiar with in terms of the nutrition care process. So we look at screening and assessment to pick up those who are particularly risk of nutrition challenges, including malnutrition. So screening for all patients, particularly those who we know are going to run in that are high risk, so head and neck cancer patients, for example, and using validated tools like the subjective global assessment, patient-generated subjective global assessment, and a whole range of other tools that do have tools and assessments that have support. So now looking at where we have moderate evidence, and I'm sure someone's going to cover it if we haven't already, is that there are a lot of challenges in nutrition research. Obviously, there's challenges just in conducting research within, people who often have multiple challenges, multiple disciplinary input, and very complicated. But nutrition, we have our own unique challenges, including if someone's malnourished, they need nutrition support. We can't ethically, withhold nutrition support. So it's always, I think, important to keep in mind that in some areas, moderate evidence is, in my belief, the strongest we're ever going to be able to get just because of some of these challenges. So looking at the particular energy and protein requirements, considering prophylactic tube feeding where necessary, or also very proactive and timely nutrition support. Now also looking throughout treatment. So we've got, once again, moderate evidence that very regular follow-up and intervention, weekly for those at high risk during radiation therapy, minimum fortnightly follow-up with up to 6 months post-treatment support. And in fact, this might even be longer for some of the head and neck cancer patients that really have ongoing swallowing and nutrition challenges. And some of the outcomes that have been looked at are a range of clinical, cost, hospital admissions, infections, all those sorts of things. And it is, of course, I think important when we do all this modelling to look at what we consider is important in terms of, survival, morbidity, cost, but I think also what's very important to the patient and their carers. And a lot of that is, of course, around quality of life. So this is probably a little bit difficult to see, but it just shows you the sort of flow chart of some of these integrated models of care. And so this is from Nicole Quiche and her team down at Peter MacCallum, a cancer-specific hospital and outpatient centre. And this was specifically in patients with head and neck cancer. And what we found was that looking at a unique clinic that was really set up to manage people impacted by head and neck cancer and looking at how they were going in terms of their eating and weight loss, and then receiving appropriate nutrition education. In this particular care, they utilised nutrition assistants or diet aids to do a lot of the more sort of general work around supplements and dietitian approved education resources, prioritising the time for the dietitian for more of those complex cases and overseeing roles, and actually found that this was rated as highly satisfactory from all the disciplines and the patients, but also led to some improved nutrition measures as well. And so then I'll highlight a study that I was lucky enough to be involved in. This was a joint collaboration between speech pathology and dietetics, led out of the Princess Alexandra Hospital in Australia. And this was a really nice study, I think, and series of studies initially focusing on people with head and neck cancer. But what we found, so we had these amazing evidence-based guidelines, recommending all this regular follow-up. But what we still found within that group was that there'd be some people that would be fine for a few weeks, but then really need much more intensive joint support by the speech pathologist and the dietitian. So how could we triage that care even better? And so we used a series of screening questions, which were then automated via a iPad or different technology, and then over time has also been done via telehealth. And this was an effective way of really identifying those patients and also carers that were really high priority and really needed nutrition, speech pathology and psychological support straight away, and those who perhaps could go another week or two before they actually were at particular high need. And this was very effective in reprioritising and reutilising all our existing resources. We found that it decreased, the no-shows and the challenges with cancelling different appointments. It did lead to significant cost savings, including almost $400,000 a year in one of the first studies. These have continued to be cost saving over time, particularly as we've increased our use around telehealth. And I think really importantly, it was very effective at getting a really good handle on symptoms, how they were progressing, and that we didn't have to keep asking the patients the same information. We had the information, all the different disciplines could access it. I highlight now the EAT study. Now, if you're not familiar with this one, I really encourage you to look into it, because this was, once again, a very interesting psychological study led by psychologists, but also jointly with dietitians and then all the other sort of disciplines supporting it. It was also in head and neck cancer patients, and it was looking at eating as treatment, so using cognitive behavioural therapy. So the dietitians were upskilled, particularly in CBT, around helping with nutrition support. And this was a stepped wedge design study with centres from all around Australia, nice sample size, and found that so basically it was standard care versus this EAT intervention, and found that nutritional status was improved over time. And this also led to other improvements, including some cost savings and some decreased, so clinical but not statistically, sort of just on the line for some of the savings in length of stay, but certainly in terms of quality of life and weight loss and nutritional status was all significantly improved. So I've shared a couple of examples of different models of care for head and neck cancer patients. Now I'm going to talk about a particular clinic, which once again is dietitians play a key role, but it is a true multidisciplinary clinic. And the benefits of this was really, again, better care for patients, more integrated care, and not having to double up on all those questions. And I don't know if anyone's done that. I've been fortunate enough to visit many cancer centres around the world, and I've loved seeing how people are tackling, such a challenging area. But on one of my experiences, I did follow patients as they spoke to all the different disciplines. And I have to say, it can be very frustrating when you're constantly asked the same questions and you feel like the different disciplines aren't talking to each other. So any way that we can more effectively share and utilise this data, I think is incredibly important. So really this was, just looking at different screening again, psychological, distress, nutrition, physiotherapy, occupational therapy. And based on the different screening, patients will be prioritised and triaged to receive a different level of sort of multidisciplinary support. And what was found with the optimisation clinic, once again, importantly, it was doable and really high satisfaction, not just from the patients and carers, but from us, from the clinicians, from allied health, from the medical team. And I think that shows that it's doable and that everyone actually really wants to do an amazing job. But anything we can do to make the systems easier is really, really important. So one of the challenges that was picked up, though, was the inconsistent messaging between the different disciplines. And any of those of us who work in nutrition know that this is actually really important, and it's very frustrating, not only for the clinicians, but obviously the patients and carers. So what we found in a range of studies is that all the disciplines feel that nutrition is very important and that it's everyone's priority. So that's fantastic news, but it really should be under ownership or led, I think, by obviously the key treating team and the registered dietitian, who then can make sure that the messaging is consistent across all the other disciplines, because there's nothing worse than being told conflicting information, particularly in an area like nutrition, where anyone just has to search up cancer and nutrition on our wonderful Dr. Google, and we're going to be hit with all this stuff, and most of it's conflicting. So as the medical and treating team, it's very important that RDs are a key part of that. Okay, I know this once again looks complicated, but it's just highlighting the flow chart going through the different nutrition care process, and yes, utilising the information from the different tools, for example, the PGSGA, to highlight either as low, high or moderate risk, and then the different interventions from that. We tend to use a different range of tools, so it might be automated, through an iPad that then automatically alerts the relevant disciplines. So we've used that effectively in many different studies and clinicians. And yes, to highlight, I can see there's a few questions coming through, which I'll attempt to do as well. For our joint speech pathology and dietetics studies, yes, we actually run a joint clinic. So in most cases, the dietitian and the speech pathologist is actually in the same room, which is very effective. And so depending on what's going on, one may take the lead and then the other supporting, and vice versa. And so we've found that can be a very effective use of time as well. And we do often use either diet aids or nutrition assistants or different assistants that can help with, and also nursing staff who've been adequately supported and trained. And we know we've got many amazing nurses with nutrition expertise as well. So, really utilising the whole team to provide ongoing support as required. And the key thing is obviously monitoring and following up, particularly post-treatment and radiation. I think we do still have that challenge that people think they've finished radiation and then everything's going to be fine. So sorry, this is highlighting in stem cell transplant patients where, often they come in well-nourished, but then leave malnourished. So making sure that there's adequate screening and nutrition support as soon as we know they're going to undergo treatment, and then all the way through. And we've actually had some really great results from a lot of these particular studies. Okay, and yes, so we know where most of the evidence is most robust is in terms of decreasing malnutrition prevalence, decreasing length of stay. We know there's other things impacting length of stay, but if we just purely look at it, take out some of those other things, improved nutritional status does tend to result in less complications, less treatment interruptions, shorter length of stay, better quality of life, and importantly, also cost savings, which I think is so important to look at, whether it's from a hospital point of view, the patient point of view, medication point of view, quality of life, all very, very important. So pulling together some of the key recommendations now is that in some areas we do have good evidence. I think we also need to understand that in a lot of these nutrition studies, moderate evidence is actually good evidence. It's actually going to be incredibly difficult, and in my mind, virtually impossible in some of these areas to ever get higher levels of evidence like you could in a pharmaceutical study just because of the actual challenges with study design and patient groups. So let's recognise the evidence that we have it. Of course, it's always good to get local data. What I think I really wanted to highlight was that we do have quite a few examples now of, I think, really interesting and demonstrated beneficial models of care, but they do need to be unique to your centre or your organisation, because there are specific differences that absolutely are going to come into play rather than a one size fits all. I think using the nutrition care process and using examples where we have them, but knowing that it's really important to get stakeholder engagement from all the different disciplines. Everyone's got to have ownership and input into it, and that regular follow-up and testing and data collection so that we know that they're actually being implemented effectively is really, really important. So with that, I once again would like to acknowledge all the amazing work from my team and my amazing colleagues around Australia. I think it's really exciting to see that it's true multidisciplinary and interdisciplinary research. Dietitians have certainly led the way in many of the areas, but we've got great examples of psychology, nursing, speech pathology, surgery, and oncology and everything else in between. So thank you very much. And once again, I also want to acknowledge the amazing work of the NIH, and I think it's an amazing initiative. And I'm really excited to hear all the discussions and everything that comes out from it. So thank you.
Thank you, Dr. Azarine, for sharing those examples and valuable perspectives on integrated models of care in Australia. We've had some really great presentations today. So I'd like to now invite all of the key question 3 presenters to turn on your cameras and join the discussion and Q&A session that's going to be moderated by Dr. Hyatt. Thank you in advance for sending your questions through the chat pod to everyone. We will continue to receive your questions throughout this session. Dr. Hyatt, you may begin.
Thank you, Keisha. So yes, we've had lots of good questions posed and answers offered in the chat. But the way we do these sessions is to first start out with the panelists. And I want to ask anybody on the panel if they have questions of the speakers, starting with the EPC report. Could somebody remove the reference slide from the screen here, so we can get a grid?
What would you like up? Robert, what would you like up?
Drop all the slides, Catherine, so we get the grid view.
Yeah.
Okay.
Out real quick. So go ahead with your discussion while Catherine does that.
Great. So panelists, do you have any questions for the speakers so far?
This is Heather. I have a question.
Heather, please.
Hi, Heather Gold. Thank you. There was quite a bit of chatter in the chat box about the risk of bias assessment, Dr. Parsons, and that was helpful. And I know that the Appendix A in your report has extensive information about methods you used to assess risk of bias in studies. One question I think for me that remains is, why did you use a threshold of 10 studies in a category to limit your bias assessment? We were just hearing about how sometimes there are studies that or areas where we may only have one, but it's decent enough or good enough, or we want to know if it's good enough and has limited bias, even if it's only one study in an area, since there's no way to do a meta-analysis with such variability in studies. Thank you.
Thanks so much for that question. I appreciate it. That is just one area where we recognize that we were trying to find a balance in our systematic review of providing an overview of the evidence that was across this very broad topic. Obviously, as you could see from the presentation, that the range of nutrition interventions went from everything from the addition of a single dietary supplement all the way through very in-depth multi-component interventions that had oral nutrition supplements and nutrition counseling. And just given the resources we had to pick. So within our systematic review, in order to keep it broad, we weren't able to go as deep as we wanted to across all of the studies, but we did want to be able to comment at some level on the quality of the studies. And so with input from our panel and our experts, we decided to focus where there was a concentration of literature which would have given us the highest likelihood to find a number of studies where we could potentially do meta-analysis. And even among those, we really struggled, as you could see, just based on the review of risk of bias within those areas where there was a concentration of the literature, finding overall that most of them had a high risk of bias. And I'll comment on this a little bit more in my presentation this afternoon, but just even among the studies where at face value you might say, oh, well, they look somewhat similar, you might be able to potentially conduct a meta-analysis on these studies. When you really dig in and you look, they may have not provided a level of detail around the outcomes or how they were measured in a way where you would really feel comfortable combining them in a way to do a meta-analysis. So thanks for that question. I really appreciate it.
Thanks.
Other questions from the panel? Yes, Karen.
Following up on something that Roan raised in talking about the importance of catching these problems with nutrition impact symptoms early on. I'm wondering about where yesterday we were discussing the importance of using validated tools for screening for malnutrition. If we rely on those, are we only catching people when they've already got enough of a problem? For example, it would require having some weight loss. If what your recommendations would be for studies on interventions on the impact on influence on these nutrition impact symptoms, if we need to think more broadly about who's included in those studies.
Well, I think in terms of clinical practice, I think there are tools already that do incorporate a number of nutrition impact symptoms, and I'm thinking of the PGSGA, which is often used as kind of the gold standard in a lot of nutritional studies, just because it does incorporate nutrition assessment factors as well as the nutrition impact symptoms and other things. So there are tools that are already available. I would say that in terms of screening across the United States right now, commonly what's used in the clinics, if they do use screening, and I think we're looking at, there's evidence, 50% of clinics might incorporate some kind of screening tool. Many of them are not even validated. So, but usually the screening tools that are selected are often simpler. And so, for example, the MST, so it's basically just looking for changes in weight or whatever, trying to, I guess, just very generic, very broad. In terms of research, then my thought would be is if they're able to incorporate the PGSGA, I think you would be able to incorporate all of those factors and in a much, I would say, if you're using it routinely throughout treatment, you're really capturing the moments when things are changing. And that's, of course, the moment that triggers intervention.
Thank you.
Great. Other questions from the panel? Okay. Let me go to some of the questions posed from the audience. This is another question for Helen Parsons, and it touches on some of the things you've already covered. But was there an attempt to look at the studies using a validated nutritional screening tool versus those that were not, maybe using something like a per hospital or author guidelines? The comment is, this seems very difficult to draw meaningful conclusions if a validated screen was not used across all articles.
So that brings up a great point, and one that we had a lot of discussion within our group about how we, and if we narrow our systematic review based on only those studies that did do an assessment using one of those validated tools. And ultimately, we decided that by limiting, as you can see from the results that we presented, if we were to limit to those studies that only use a validated screening tool, that we, or any screening tool at all for that matter, we would have lost about half of our studies or more, because in many cases they were just not conducted. The authors indicated that potentially these individuals were at risk for malnutrition, and therefore they would be implementing these nutrition interventions. But I think it does bring up a broader point of the need to use these standardized assessments when these interventions are being conducted, and to also use or maybe have some discussion around using consistent tools as well, because even among the studies that did use those validated tools, there was a pretty broad range of the tools that were used, and I know that that's context dependent and practice dependent as well. Everywhere from anything from the MST to the NRS and some other tools as well. So I think that's a great point, and one that I would encourage future research to adopt in these consistent use of these validated tools when conducting these interventions.
Good. I think that's a point that's been made several times, and thanks for reinforcing it. Another question that anybody can answer, and I'm glad that Dr. Eisenring is on the screen here, because as a non-US investigator, she may have a particular perspective on this question. So this questioner is curious to find out from anybody why so few studies have been conducted in the US compared to other countries. Is it lack of funding, universal health care, medical culture or belief around nutrition support? This is a question that was raised yesterday about studies as well. So Dr. Parsons or Dr. Ron Levin or Dr. Eisenring, do you have any insights on that observation?
I might just start from, my perspective, obviously not knowing the US situation, but what I will say is that, even Australia, getting these studies, particularly the large studies and getting the funding, is incredibly challenging. So getting, national funding for which some of these larger trials, we received, like anywhere, it often takes years. It requires good pilot data, extraordinary research team. So it's certainly not easy. And that's in the best case scenario. I do think we have challenges that, once again, if we get industry support, then of course there is going to, often be bias towards particular products or, particular way of doing things. So I do think the funding situation is very, very challenging. And, I'm really looking forward to finding out more about Helen's presentation, because I'm very curious. But I guess from my perspective, I just like to acknowledge that there's so many challenges and difficulties in running research, particularly multidisciplinary research in this area and large studies, so that, to have big numbers. I mean, it's super hard. It's hard to even get one or two really nicely conducted. So that's from my perspective. I'd love to hear from the US perspective.
Yeah. Anybody else have thoughts about why that observation is true? I guess we need some investigators from Asia and Europe who seem to do better at this than we do. But it is curious. You'd think that given how difficult it is, even given how difficult it is, it would not result in such a discrepancy. Ron Levin, do you have any thoughts on that?
I was noticing a lot of the current studies that are available are specific products that are in the that are being developed in the United States for sale. And so, it looks to me like funding issue more than anything else. So if you look at the different individual oral supplements or, related to surgery, pre-surgery, rehab, so I'm guessing it's more as a funding issue than anything else.
Great. Okay. Thank you for that. Another question from a participant. Why is the NCCN not reimbursing for dietetic oncology services? This will be the first and limiting step to enhance patient care. We'll also allow us researchers to be able to perform rigorous and high quality studies in evaluating nutritional interventions. How can the NIH or federal government mandate that reimbursement will allow for more dietitians to participate and be involved in the care of cancer patients? There's a question about coordinating with NCCN.
Well, I can maybe start with that, and I think I would just clarify that NCCN isn't the one necessarily. They aren't reimbursing for the services. Those would be the insurance companies like this and other agencies like the Centers for Medicare and Medicaid Services that would actually be reimbursing for those services. And so I think in order for that to happen, typically what happens is there's a panel essentially that goes to CMS that then reviews the current evidence and then makes a decision on either a national or a local coverage determination. And typically many of the other private insurers then follow in terms of their adoption or addition of coverage decisions based on the leadership of CMS funding decisions. So, as an opportunity, I think, first of all, getting high quality evidence that is applicable and can be implemented within the US based setting would be an important first step. And then from there, using that as an opportunity to then advocate within the CMS in that funding pathway.
Agree. Any other comments on that?
I'd like to just add that if NCCN isn't recommending it, I don't know that CMS would be interested in reimbursing. And actually through the work, through the ONDPG, the Oncology Nutrition Dietetic Practice Group, which is the kind of oncology underneath the Academy of Nutrition and Dietetics, that is actually an effort that we've put forward, is to provide information to NCCN to submit information about what is the current state of the research. And we have been successful in getting in some commentary in terms of like head and neck cancer and pancreatic cancer. So, and continue to submit that type of information, but it's coming from a very small group versus if we had, great research that we could support that.
Good point. Another participant comments that we need better biomarkers to indicate when weight loss turns into malnutrition. For example, going from a BMI of 35 to 25 suggests that the adipose stores have been appropriately used in the setting of negative energy balance. That may be a lot of weight loss, but is this person malnourished? This sort of gets back to the definitions that we approached yesterday. Anybody want to take that one?
I'd like to just make a comment that I agree with all of that. The question would be, is the patient malnourished? And taking a look, and this would be part of the assessment, would be what kind of factors are they undergoing? What kind of stresses are they undergoing? And so just looking at it as a number versus the, additional effects of the treatments and the stresses that the patient might be under might put better context on that. But yeah, it would be great if we had better markers that would be very clear. And actually, in terms of the areas that are reimbursed by CMS, which includes diabetes management, the way that the factors that they use to be able to show or proof of nutrition intervention being effective was having the hemoglobin A1C marker. So they were able to show or demonstrate with a very simple marker. Unfortunately, oncology isn't as clear cut as that.
And I'll just add, great comment. We could speak about this for days, I'm sure, but, also the importance of actually body composition, which I'm sure some of our experts are going to be talking about as well, as rather than just, fat loss and then all the other things that we want to look at it as well. So I agree, but from my point of view, I still think it's going to be a composition of various assessments because we don't have that one magic marker.
This question's, thank you for that. This question's rather lengthy, but let me give it a try. As nutrition is increasingly recognized as I should say malnutrition perhaps, primary cause or contributor to cancers of various types, largely due to the common pathway of inflammation, comprehensive and integrated lifestyle support needs to be provided to all patients, most certainly cancer patients. The Lifestyle Medicine Research Summit summarizes the role of plant-based eating in preventing, treating, and reversing chronic disease. Hospitals have frankly to get with it in eliminating or reducing subsidies for inflammatory causing foods, both in the wards and the cafeterias. Nutritionists and clinicians need to lead the charge on behalf of our patients. This question is directed to Ron Levin and Dr. Eisenring.
I would just comment that I agree, but that you know, there's a lot of factors that go into it, and I can tell you right now that in terms of the hospital setting, usually the food and nutrition department, which is often completely separate from clinical nutrition, is you know, basically its own money generating situation. And I know there are hospitals that have gone that route, but yeah, I agree.
There was another question that observed that a particular hospital was serving McDonald's in their cafeteria, so it reinforces your observation. Any other comments?
If I can, well, just
Karen?
a thought for all of us is that we also need to keep in our awareness that preventive nutrition that reduces risk of cancer and other chronic diseases may not be the same as nutrition that's implemented during a cancer treatment. And so those are in another way sort of two separate issues, I think,
Yes.
that we want health promoting food, but that still may be different than what someone's appropriate for during treatment.
Excellent point.
Yep, echo that. And also just saying from my experience, yeah, the cost is a big factor. You know, we found across Australia that in hospitals or aged care, for example, you know, typically $6, $7 a day for all the meals and everything else. So incredibly difficult to make something really nourishing, even with the best chefs. But there have been some really great examples, like Rowan's also mentioned, including ordering from the bedside, you know, room service, chefs, and all sorts of things, which can show that it often doesn't have to be that much more expensive, much better quality, and also less wastage. So I think there are some innovative ways we can go, but it is financial, and it's also getting all the systems to talk to one another.
If I could just build on that really briefly too, I think we also need to think about the context in which cancer care, especially in the U.S., is being delivered, and just the increasing cost burden that patients are experiencing as they're going through their cancer care. And you know, and it was beyond the scope of our systematic review, but we also need to be mindful of the context in which some of these interventions are then delivered and would be ultimately disseminated. And you know, if we're you know, just with the cost of cancer care increasing, then having that be an additional burden onto patients, they then are having to make those decisions between choosing between high quality or guideline recommended care, and then all of the other things that continue to go on in your life when you're navigating a cancer diagnosis, such as, you know, you still have to work and find your insurance and all of those other things, trying to then balance and find healthy meals that adhere to some of these recommendations can be additionally challenging for patients and their caregivers.
This is a
Could I add
question.
one
Oh,
very
sorry.
quick thing, if I can, completely
Oh,
agree.
please, yeah.
But I do completely agree. But I just want to say all our research shows, though, that the patients and the carers really want good nutrition stuff. And if we and the experts don't provide it, they're going to get it from somewhere. And often it's from people selling products or not evidence-based. So that's my, but I absolutely hear what you're saying. But I think there does have to be some expert-led guidance.
Here's a question that I'm pulling out from the many that have been offered. We're not going to get to all of them, but this one asks maybe to Dr. Eisenring again, from a dietitian practicing in South Africa. In your experience, with your opinion perhaps, what would be the best approaches in nutritionally assisting cancer patients that fall within low and middle income settings, often with multiple chronic diseases.
I would say it's looking at any care that we can. So once again, from my experience, it's utilising National Cancer Organisation that do a lot of telehealth. It's using local community groups and volunteers that might be able to do things in particular languages. And I guess it's prioritisation. And in this case, you know, some of those issues that Helen mentioned, completely right. If they're worrying about paying for things or not being able to work, of course, those are going to be front of mind. So I think it's really about trying to link the existing services and any sort of patient and volunteer support. I have found that actually a lot of the volunteer patient and carer groups, you know, at least that I'm familiar with, can be incredibly effective and actually bring in experts now and again to make sure that it's all pretty evidence-based. But then there's a lot of carer support there. But I agree, it is a very challenging area.
Thank you for that. Another comment is about cooperative groups. There's no nutritional oncology cooperative group anywhere, and therefore no clinical trial infrastructure. Cancer research cooperative groups are valuable allies. SWOG, as discussed yesterday by Dr. Hamilton Reeves, is an example. The European Palliative Research Center recently supported the international MENAC study of multimodal nutrition, exercise, and anti-inflammatory therapy, where 250 patients were included with sites in 10 countries, including Europe, Canada, and the US. So that's the comment. I guess the thing the participant is looking for is some comments from the panel or the speakers on the value of cooperative groups and the lack of them, maybe with the exception of SWOG. Any comments?
Can I come back a bit to evidence and, you know, whether it's the need of a cooperative group, and maybe this question goes to Dr. Levin about NCCN recommendations. We've kind of circled around how it's needed, some options in the hospital. It's expensive in the hospital, but also in the U.S. we're calling that most cancer care, most chemotherapy or systemic therapy-based treatments are in the outpatient sector. So the hospital piece is perhaps not as closely tied to a payment rule, and that's where I'm going back to. So would it be correct to say that evidence base is needed in cancer care in a community setting, predominantly in an ambulatory setting, with a biomarker for NCCN to then recommend to CMS to consider payment rules? So I kind of am circling about, but it just seems like in the absence of a covered benefit for both Medicare and privately insured, Medicare, Medicaid, and privately insured patients, how are we going to move this forward? Yet to move it forward, we need evidence from the communities, and that evidence needs to be a biomarker that is collected perhaps in a community-based trial.
From my perspective, I don't know that a biomarker is going to be possible. I don't know that there's anything that we'll be able to come up with that's going to be able to help with this. From my understanding, and this is partly from in 2015, 2016, we did a program on access to nutrition care and through Institute of Medicine and National Academies. And one of the things that came out of that was that you actually need very little data in terms of showing money savings. Like that, I think if you were able to show financially, even just small increments of improved outcomes, and I think that's where I was kind of going in my talk, where I was suggesting that we don't really look at there's pretty clear evidence in terms of many different cancer types that patients who are nourished complete their treatment more effectively and more efficiently. So, so there's less treatment breaks, there's less treatment holds, and all those things are negative prognostic indicators. We spend all this money on treatment. We spend all this money researching how do we get patients to get the best treatment, and then we allow them to fail because they're malnourished. You know, it just doesn't make sense. So I think that that's an area that if we were able to show, you know, that patients were able to get their treatment and, you know, the amount of money it would cost to help close those gaps, I think it would be, I think dietitians and nutrition basically are a cheap, low-hanging fruit kind of thing in terms of all of the money that's invested in cancer research. And I think that, so to answer that question, I think actually being able to demonstrate improvement in costs, and I think that that is probably the direction that will be the quickest way to demonstrate what we need to be able to be reimbursed.
Well, my name is Michael Pollock. I'm speaking from Canada. I'm going to be talking later, and I think there's a problem of cause and effect and chasing your tail, because you're saying that I think many of the speakers made a clear-cut case that the costs of providing the nutritional counseling on a community basis to all the needy patients is a very high amount of money. So the burden of proof that there's benefit is high, because we're talking about the argument is being made that maybe there could be cost savings, but there's also costs required to deliver the care. This is not line item in the cancer center's budget. So I think it's a little bit of a circular argument. And at the end of the day, I think most people would agree that it all depends on data. I mean, if there was clear-cut, unequivocal evidence of efficacy, then it would be relatively easy to get the payers to pay. When we talk about efficacy, however, completing chemotherapy is not really a sufficient endpoint. The sufficient endpoint has to be benefits in like any other component of cancer care, you know, survival, disease-free survival, maybe quality of life. The short-term endpoints, like with nutritional counseling, more people could complete their chemotherapy. I don't think that would cut it, because that's not really something that people would be willing to pay for, that people complete chemotherapy. The real endpoint would be, because they completed chemotherapy, they actually had better overall outcomes. And so that's why we're, I think, stuck, because we really would need to make a strong case for liberating a lot of money to improve dietitians' access to cancer patients. We need a better metric, not a biomarker, not completing chemotherapy. We need survival data. We need real big data that the public would accept, like, yeah, we're going to spend $500 million on dietitians because our cancer patients will live longer or be happier. Not just because they could complete more cycles.
No, I agree. And I think that's what I was saying. That's actually where I was going with that, is if there was a way to demonstrate that with nutrition support, more patients were able to live longer because they were able to get their treatments. And I like to use the data, for example, in head and neck radiation therapy. So the average starting point for a patient going for head and neck radiation therapy is that they're going to have 15% benefit, and every day that they miss of radiation therapy because of whatever reason, getting a feeding tube placed emergently or whatever, they miss 3 days, every day they lose 1% of efficacy. So those kinds of things, and you know, it's easier to see like in those high risk patients like head and neck cancer or pancreatic cancer, but I think that there's some opportunity there to be able to demonstrate that with support patients do better, they get their treatments. And yes, we're never going to be able to say, you know, the nutrition fix this, and you're never going to spend $500 million on dietitians. Yeah, I think that's where I was going with that. I also wanted to comment just on the idea of, already we are, because of a screening tool, we are already providing adequate social work, just as another allied health kind of professional in those cancer centers at a rate that's about 6 times what we're providing for dietitians. And what we're providing is quality of life measures. And so I just wonder, is there not an opportunity in that direction as well? We can demonstrate that that nutrition support improves quality of life issues for patients who are suffering during cancer treatment. So, and it just kind of blows my mind that we're willing to give people quality of life support in that direction and not in nutrition direction. So anyway, just a thought.
And I would just echo that, yeah, certainly in the quality of life, I think we've already got some reasonable data. There's very small amounts around the survival, but I did see someone comment that, of course, is the challenge, the length of time, the big patient numbers that you need. So any that we do have in that, it's tiny, it's very weak data, just because the studies weren't designed for that. But in terms of quality of life using validated tools, I actually think there is evidence there, particularly in those high-risk groups like head and neck cancer, gastro and lung.
Yeah, this reminds me of a comment I think that Dr. Gold made yesterday. And the reason why there's no cost-effectiveness studies is you first have to have effectiveness in order to do those kinds of studies. So that's the research challenge. So we have just a couple more minutes left in this session. Dr. Collins has a question for Dr. Eisenring that maybe she can ask verbally that has to do with cost savings in the screen IT studies.
Just wondering if you could give us more detail, Dr. Eisenring. You noted the cost savings, and if that's going to be one of the elements that we use to make the case, then maybe what are the broad elements of cost savings that we need to include in that data?
Absolutely. I'll do it broadly now, and then I suggest I'll actually send you some written stuff, considering it is 4 a.m. and I'm not completely over it. But what I will say, key cost savings were in terms of reprioritizing staff and actually freeing up staff time, because they're actually seeing the patients that needed to be seen instead of just routinely seeing them based on a time frame. It was actually based on a triage and requirement point of view. In some of the early studies, overall, they led to hundreds of thousands of cost savings per year. In terms of patients, top of my head, multiple thousands per patient. And then, of course, what I think is pretty exciting with some of the latest stuff we're doing now is around telehealth. And that's actually led, it still tends to be integrated with some patient and actual in-clinic care. But the telehealth, although there is some cost, obviously, to setting up some of the telehealth, in terms of actual overall cost savings, they are quite significant. So I will provide a little bit more written information so that it's a little bit clearer. But what I will say is that in terms of service cost savings to the healthcare facility, they are significant. And I think what's really important is the satisfaction from everyone, carers, clinicians, and the patients themselves, even including the high risk and the very old that we thought would not perhaps be able to take on board, some of the technology or doing stuff with phone. But, perhaps that's been one of the silver linings of COVID. Suddenly now, a lot of this work actually did start pre-COVID, but obviously the whole COVID experience has just made it more widely acceptable.
Just a follow-up, do the cost savings tend to include things like hospital admissions, since most of our care is administered outpatient?
Yeah, some of the work we've done is around unplanned hospital admissions. Yes, in some cases, also looking at the treatment interruptions, echoing Roan's point as well. And what's the other one I wanted to say? Yeah, unplanned readmissions. Yeah.
Thank you.
In the last couple of minutes, I want to make sure the other panelists don't have any remaining questions. Dr. Truesdale, do you have any questions? Dr. Layamo, any questions? And Dr. Clayton? Good. I think we got it covered. So back to you, Keisha. I think this session has been very successful in terms of surfacing a lot of the important questions. Thank you all, panelists and speakers.
Many thanks to our presenters and our moderator for this engaging portion of the workshop. We will now take a 10-minute break to prepare for the next part of our workshop. To help keep us on time, there's a countdown clock that's going to appear on your screen. We ask that you please return so we may begin on time with the continued discussion of key questions 1 and 2. Thank you. Welcome back, everyone. Good afternoon and good morning to everyone joining us from the Pacific time zones. We hope you have some time to refresh and are ready to begin a subset of key questions 1 and 2, which will address: do the effects of nutritional interventions in preventing negative outcomes of cancer treatment vary by age or among special population groups? We will hear from 5 presenters on this key question. Following the initial presentations, we will take a brief break, return to hear from the remaining presenters, and then hold a discussion and question and answer session moderated by Dr. Hyatt. Questions are being received through the chat pod sent to everyone and will be answered during the discussion session. First, we have Dr. Helen Parsons from Minnesota EPC. presenting Nutrition as Prevention for Improved Cancer Health Outcomes, key question 1B/2B and 1D/2B. Dr. Parsons, you may begin.
Thank you, Keisha, for that introduction. And on behalf of the Minnesota Evidence-Based Practice Center, I'm excited to present the review from our on our key questions, specifically some of the sub-questions today. Just briefly, as a review, we presented the overall results from key questions 1 and 2 yesterday, but as part of the systematic review, we were also asked to identify whether there was a literature base that evaluated whether the effects of nutrition interventions varied across the lifespan or across special populations, such as among individuals with multiple comorbid conditions or pregnant or lactating individuals. I have already presented this once today, but I know people are kind of hopping in and out of the presentation. So just really briefly, just to highlight again, the criteria for studies that were included as part of our systematic review. We focused only on studies of adults that were diagnosed with cancer. We did include a broad range of interventions, and for these particular key questions were focused on a wide range of outcomes, including things such as dose tolerance, hospital utilization, adverse events, nutrition status and changes in weight, malnutrition, and BMI. And we included studies across a wide range of settings. But just to highlight again, these were only interventions that were focused on interventions delivered prior to cancer treatment as well as during cancer treatment. I won't go into this again in much detail other than to focus on the fact that after conducting our literature search, the literature was limited to randomized control trials that randomized at least 50 participants, again, to identify the highest number of studies with high quality evidence. And we focused on identifying information on the study design, participant characteristics, interventions, and outcomes, but only focused our risk of bias on a subset of studies where there was this concentration of literature among nutrition interventions and cancer types, and we're able to categorize based on our risk of bias tool for those studies, whether they were a low risk of bias, which indicated higher study quality, or a high risk of bias, which indicated lower study quality. And because of the heterogeneity, as we've discussed throughout the workshop, it was not feasible or appropriate to conduct meta-analyses. So I want to start before we even talk about the subcategories to just take a step back and look at the overall results for these key questions or across all of our key questions. Briefly, we identified, as you can see, after identifying about 9,000 records, there were about, after title and abstract review, about 1,000 that were potentially eligible for inclusion, and those underwent full text review. Ultimately, we identified 184 studies from 194 publications that were included across the 4 key questions and contextual question for our systematic review. This slide shows an overview of where there was a concentration of the literature and by key question. As you can see, the majority of studies were really focused in that key question 2, which was where nutrition interventions were delivered after treatment began. There were fewer studies among studies where they were delivered either prior to the initiation of cancer treatment, or they may have potentially started, in the week or 2 before cancer treatment and then continued on after treatment began. So there were 32 of those studies. Most of the studies were really in the nutrition support space, as well as dietary supplements, as you can see, with fewer studies focused really in the special diets, as well as nutrition counseling or multi-component interventions. Across all of the included studies, most of them were conducted in the inpatient setting, and further, the second most common was an outpatient setting. Most of them were conducted in populations who were receiving surgery alone as their predominant type of cancer treatment, followed by individuals who were receiving multiple therapies, such as surgery and radiation or surgery and chemotherapy. Across the entire data set, we also saw that most of the studies, or over half of the studies, did not use screening tools to quantify malnourishment. They also did not adequately provide information on who prescribed or delivered the intervention, but when they did, it was most often a dietitian or a nutritionist. The most common route of administration for these studies was either an oral or an enteral administration. And again, they focused really on studies that were, the studies were predominantly published in Asia and Europe, with few in North America. So taking a high-level view across these key questions, we found that 2 decades of randomized trial evidence on interventions delivered both prior to and during cancer treatment really focused on a wide variety of nutrition interventions, everything from dietary supplements to nutrition support, as well as the route or timing of nutrition interventions. They were predominantly among gastrointestinal and head and neck cancer patients. And a further caveat is that they were predominantly in the inpatient setting. They did evaluate a number of different outcomes, including things such as weight and body composition, adverse events, length of hospital stay, and quality of life. However, I will mention that those were not always the primary goal of the studies, and oftentimes they may have been looking at things such as clinical or other biomarkers as terms of effectiveness. There was a high heterogeneity across the study populations, the interventions, and the outcomes, and I'll get into those in just a minute in a bit more detail, even within the nutrition categories. Further, we found that when we did conduct a risk of bias assessment in those areas where we found a high volume of literature within a specific cancer type or nutrition intervention, most of the studies, over half, were rated as a high risk of bias, indicating a lower study quality, while only 10% were rated as a low risk of bias. And when we focused in on the low and the medium risk of bias studies, they overall found mixed results on the effect of nutrition interventions across the outcomes of interest. So this is where we get to the sub-questions. And I wish I had more information to present on this, but I will just say that although many of the studies may have enrolled individuals across the lifespan, which is one of the sub-questions for question 1 and 2, or enrolled some of our special populations of interest, such as those with multiple comorbid conditions, the studies did not individually report the results of the interventions across these categories, and so it was we weren't able to present that information in our systematic review. Further, the studies rarely aimed, nor were they statistically powered to examine variation in cancer studied or in the types of healthcare providers and where they were delivered. So as a result, it really is difficult from this literature base to determine the broader applicability of findings, particularly when, for example, a specific nutrition intervention may have been given to patients with a specific cancer, with a specific type of treatment, and in a specific location. So for example, you may see a nutrition intervention that was delivered to early stage gastric cancer patients in an inpatient setting using oral nutrition support. And it can be challenging then to see how that might apply to other cancer types or stages. Additionally, it could be challenging to determine the broader applicability of these findings for patients that may have been treated in different settings. So for example, would these findings then be applicable to an outpatient setting if they were delivered in an inpatient setting or by different clinicians? So given that there was less evidence across some of these key questions. What I'd like to spend some time on is where there are some opportunities for future research needs as a way to consider as we move forward. So I'd like to start with an overview across these key questions and really across all of the key questions more broadly of the limitations that our group noted in conducting the systematic review. First, as you can see in the presentation of all of the types of nutrition interventions that were encompassed by the systematic review, this is an extremely broad topic, and it ranged in interventions from adding, for example, an arginine to an inpatient food to all the way through a multi-component intervention that may have had nutritional counseling combined with oral nutrition support over many months. And so it really was a wide range of nutrition intervention types. Further, the interventions really varied by the populations they enrolled, focusing predominantly on gastrointestinal cancers, the interventions that were delivered, the timing and the mode of delivery. Some were short inpatient interventions, others were longer outpatient interventions, the comparators that they used, as well as their outcomes. And so overall, this substantial heterogeneity across the types of interventions really made aggregation infeasible. Further, I'd like to note that there was significant challenges with the methodological rigor. Overall, the literature really lacked a clear conceptual model for how the interventions would improve outcomes. In many cases, it seems like maybe it was just added into the care that was delivered in that setting. And so oftentimes there was a lack of adherence to very basic reporting standards, such as to the consort diagram. And so oftentimes our group would have a challenge identifying who received the intervention, what exactly they received, and what quantity, who the comparator populations were. So as a result, most of the studies were rated as a high risk of bias or lower study quality. For the populations overall, they were predominantly conducted in gastrointestinal and head and neck cancers, and so it's challenging to know whether these could be then extrapolated to other populations. And as a result, we saw that the literature really lacked stratification by the key subgroups that were of interest to the review panel. There was additionally a very strong focus on specific populations within studies, as I mentioned, early stage gastric cancer, and that may limit the broad applicability to how that might affect or it be implemented in other populations. And finally, there was a vague and wide-ranging definition for how these studies really categorized at risk for malnutrition, ranging from everything, including saying that if you were diagnosed with cancer, you were at risk for malnutrition, to using very specified tools that were validated with particular cutoffs in order to identify people that were eligible for this study. The interventions themselves were extremely heterogeneous, even within the intervention categories. So, for example, we'll go back to the dietary supplements. Even among studies of, let's say, an omega-3 fatty acid, we saw that across different studies, there was a wide variation in the dose that was used, the duration, the route of administration, as well as the context, where you're using it in the context of cancer treatment or prior to or after or during cancer therapy. And finally, the comparison populations really varied widely and were not often well specified. I can name multiple examples where the only thing is said about the comparison population is that it was relative to the standard of care. But as we all well know, that the standard of care can vary significantly across different settings, particularly depending on where treatment's delivered. For outcomes, the outcomes were highly heterogeneous, even across the outcome categories. For example, for adverse events, we saw a number of studies where they may have said that there was a surgical complication, but you don't know how it was identified, according to what criteria, and so there was really a lot of variety in how those were evaluated. They were often poorly defined with very few details on the timing or definition. So who actually evaluated these and were they using validated tools? And they rarely reported differences in nutrition or length of stay, which, as we noted, that the majority of these studies were in an inpatient setting. Length of stay can significantly impact how possible it is in order to identify some of these outcomes of interest, such as adverse events. And finally, in terms of the context, we need to be mindful about the implementation and realize that most of these studies were conducted in non-US settings and consider how applicable or feasible these may be in a US setting. So going forward, there's a number of opportunities. First of all, there's an opportunity to develop and adopt a more comprehensive and clear conceptual framework for the field as a whole around where the nutrition interventions can most influence outcomes and where those interventions should which nutrition interventions might be prioritized. Additionally, there's an opportunity to improve the methodological rigor using consistent criteria and reporting. There's a number of tools that are available in terms of publication reporting, such as the consort statement, and adherence to these standards would be important going forward. Additionally, testing the interventions that might be the most broadly applicable to those with the greatest need. So considering those who may be at either the highest risk or the greatest burden, and potentially focusing resources and development of interventions within those areas. Further evaluating interventions that may have a strong clinical foundation for effectiveness in preventing adverse treatments and outcomes. So thinking back to some of these key subgroups where the studies were not necessarily powered, nor did they report on some of the key subgroups, there's an opportunity going forward to evaluate outcomes amongst those groups. Using standardized outcome assessments, that was another key takeaway from our group in noting that finding tools that are used, that are validated and used consistently across the studies, maybe using a core set of tools could be one opportunity. And then finally, considering the development and the applicability of these interventions within a US context. And we fully recognize the under-resourced nutrition professionals, as has been presented throughout this workshop, as well as the reimbursement challenges. But as was noted, identifying the efficacy first in order to then support those challenges going forward. Finally, going forward, I think we need to consider the use of new research that can bolster the nutrition intervention evidence around this cancer treatment. As we've shown here today, the current study quality and the heterogeneity really did limit our ability to translate findings going forward into clinical practice or the development of guidelines. So there's a significant opportunity going forward to coordinate efforts in order to improve evidence on nutrition interventions so that not only clinical care providers, but as well patients and their caregivers can identify which interventions may best improve their outcomes in order to guide their patient care and their policy. All right. I think that's, oh, sorry, last thing. If you would like more details on these findings, please feel free to go review the full evidence report, which is now available for a 4-week public comment period at the NIH website on this slide.
Thank you, Dr. Parsons, for the evidence synthesis for key question 1 and 2 sub-questions. Our next presenter is Dr. Cindy Thompson. She will discuss addressing the at-risk populations and will also present slides on behalf of Grant Williams, who is unavailable, on malnutrition in the older adult. Thank you in advance for covering this important content. Welcome, Dr. Thompson. The floor is yours.
Thank you so much. Can I have that first slide?
I've made you presenter so you can advance your slides.
Oh,
Oh, I
okay.
thought I did anyway. Oh, I'm sorry. Let me take presenter back.
My understanding was you were going to.
That's fine, I can. These are the right slides. How come they're not coming up? We're having some technical issues here for some reason. Let me see if I can.
If you want to allow me to share content, I will do my best to do so.
Let's see if I've solved the problem here. We will do that if this doesn't work. All right, are these your slides? Awesome. Do you want me to go ahead and advance them for you?
Thank you.
Sure.
All right, thank you to the organizers and for this opportunity to really participate in what hopes to be a paradigm shifting workshop in terms of future of research and clinical practice. I'm Cindy Thompson. I'm a professor in health promotion sciences at the University of Arizona, where I am also the associate director of population sciences at our University of Arizona Cancer Center. Next slide. I have no disclosures related to this presentation. Next slide. So I've been asked to kind of think beyond the at-risk groups that they've talked about throughout the conference in terms of the type of cancer people are diagnosed with, and really think about some of the demographic factors that may drive risk for malnutrition in our cancer population. And there are many potentially at-risk populations, but what I'm going to focus on today is those diverse racial and ethnic groups, older adults, rural residency, low socioeconomic, or those living in poverty. And as mentioned by our review of the evidence, you will realize that this evidence is very limited, despite the fact that I will share with you evidence that these are populations that are at higher risk for malnutrition related to cancer. Certainly, people may fall into one or more of these groups in terms of their risk for malnutrition, and we really want to acknowledge the underlying role of social determinants of health that impact the quality and of care and the risk for malnutrition in these population groups. Next slide, please. So I want to start, as requested, by addressing some of the research gaps and where we are. You know, basically, research assessing nutritional interventions in adults during cancer therapy from some of these underrepresented groups in biomedical research is basically very limited. And yet these populations, as I'll try to demonstrate for you, are at higher risk for malnutrition. Current nutrition and diet guidance during cancer therapy that was shared earlier suggests that the guidelines have relevance across at-risk group, but many of these guidelines could not present specific data because of the lack of research. And implementation of nutrition interventions in cancer care should consider relevant adaptations for these groups in terms of developing programs going forward. Next slide, please. Now, as you have already heard throughout the conference, medical nutrition therapy has the potential to modify clinical factors associated with malnutrition. And certainly treatment-associated symptoms have been improved, inflammatory metabolic markers, body weight, and at times body composition. And we may even see improved control of comorbidities with medical nutrition therapy. But importantly, we also see some disparities across these at-risk groups in terms of, for example, symptom burden, which in research that we're doing with Hispanic breast cancer survivors suggests that they carry a much higher treatment-associated symptom burden than their non-Hispanic counterparts. Next slide, please. Now, there's not time to address all the disparities, but I wanted to emphasize a few and kind of point out why these groups might be at risk. Certainly, we know that age can drive cancer risk. Nearly 3/4 of our cancer patients are over age 60, and the diagram on the left shows how this is projected to continue to increase over time, particularly in the older age groups. Comorbidities are often much higher in terms of the number of comorbidities and perhaps the control of comorbidities in these older age groups. In addition, 1 in 5 cancer survivors resides in a rural area, and survival after cancer demonstrates racial and ethnic disparities for several of the cancers. Next slide, please. Next slide. Now, obesity, as we all know, is a risk factor for now 14 different cancers. And we know that in terms of this end of the malnutrition spectrum, there is disparities across various groups in terms of the prevalence of obesity. And we also know that obesity prevalence can increase with age until about age 70. But particularly when we look at body composition, which we'll hear more about later, we see increase in adiposity and a reduction in lean mass related to aging. We also know that there's an interplay with education and other socioeconomic factors that can drive obesity risk, and obesity prevalence is higher in rural residents as compared to metropolitan counties, even when you control for race, ethnicity, age, and sex. Next slide, please. Now, diabetes as an obesity-related comorbidity is also disparate across these at-risk groups. We know that diabetes, or type 2 diabetes in particular, increases in older adults. We know that we see disparities across race and ethnic groups. We also know that the rate of diabetes is higher in rural areas. So all of this in terms of comorbidities, which may impact malnutrition, are also important to consider as we move forward. Next slide, please. When we think about diet behaviors in these at-risk cancer groups, overall, we see a low adherence to lifestyle behaviors across America, but we also see it in terms of racial and ethnic groups, rurality, and even in older cancer survivors. And I present to you just one study from The Ohio State University, an observational study. 68% of the patients that they surveyed were in active treatment. And what they found was that there was a high correlation between the low adherence or diet quality and factors such as lower education, employment, lower income, and smoking status. Next slide, please. So basically, the prevalence of cancer-associated malnutrition among diverse populations, as was shown, is really not well characterized. However, we would expect that based on some of these other data, that there is a very high likelihood that these individual groups are at greater risk of malnutrition. And that malnutrition may even be present, is likely present, even before the diagnosis of cancer. Next slide, please. So as reported, there aren't many interventions. I'm just going to mention this one systematic review of 14 studies by Forbes in 2020, where most of the trials were looking at improvements in quality of life as well as specific treatment symptoms such as fatigue and anxiety. But overall, this systematic review concluded, similar to the review we've just heard from, that there is a gap in tailored nutrition advice or interventions in older adult cancer survivors. Next slide, please. Next slide. So we have recently done a systematic review among rural older cancer survivors, And again, you know, this was not just during treatment, but even after treatment. And again, what we get from these systematic reviews is that there's a lack of data, that telephone counseling, it can be used to promote weight control in individuals. We can see changes in fruit and vegetable intake, but really we're not getting data in terms of disease outcomes. And I would say where we are now in terms of this literature is that there's evidence that we can enroll and intervene with older survivors as well as rural dwelling survivors. Next slide. So I wanted to point out that recently we've seen funding come through from the NIH under the ANECTO funding mechanism. This is exercise nutrition interventions to improve cancer treatment related outcomes. All of the studies will be looking at relative dose intensity. And while they're not perhaps designed specifically to look at these at-risk group, a few of them will be, and will be powered in terms of, with the Yale-Miami study, they'll be powered to look at Hispanic ovarian cancer survivors specifically, and the Penn State's Dana-Farber study will be enrolling older breast cancer survivors. So we will get some new data coming forward from these recently funded trials. Next slide, please. So what do we need? I mean, obviously reimbursement is important. We've talked about this. We're going to need more information, more well-designed studies. Are we going to need it for each cancer, each treatment, for each at-risk group? This could take decades to develop. And so, you know, can we really justify waiting all this time for the evidence? And, you know, what can be done in the meantime? We know there's reimbursement for some of the comorbidities that I mentioned today, and certainly many of our cancer patients have these comorbidities, and the rates and prevalence of these comorbidities is higher in these at-risk groups. So we may be able to leverage current reimbursement for diabetes, weight management, etc., in this setting. And then certainly that would move the field forward to some extent. Next slide, please. So my key recommendations in thinking about what can we do, what are some of the next steps, I am really intrigued by the IC3 effort that brought tobacco cessation to our cancer centers and really changed the face of tobacco cessation support for our cancer patients. And I'm wondering if we could think about a mechanism through at least to address malnutrition screening in the CCSG setting, and maybe even move beyond screening. I also wonder about developing some kind of national database in order to really track the malnutrition diagnosis and really look at the diverse demographics that influence malnutrition in our patient population or are associated with. And then I have the opportunity to work with the CDC-funded Cancer Prevention and Control Research Network that do a lot of work in D&I science in these at-risk populations. And I'm wondering if we couldn't consider partnerships to advance at least D&I science in terms of implementing programming in our cancer care settings. And while new research with at-risk populations is informative, I'm concerned if, you know, how long are we going to wait to intervene in this really important area? And finally, I think there really is a call to engage the diverse at-risk cancer survivors in this conversation and get their insights as to where we need to go to enhance their outcomes. Next slide. Finally, I just want to remind us that it's really important that we fund the training of the next generation of diverse oncology nutrition researchers, because that is going to move the needle on this issue. Thank you. Next slide, I'll be moving into the presentation by Dr. Grant Williams, who is an associate professor in medicine at the University of Alabama. He's a medical oncologist and geriatrician who's been very active with the ASCO efforts to address quality care for older adults with cancer. Next slide. No relevant disclosures. Next slide. All right, so age of diagnosis of cancer in the general population shows that many of our patients are diagnosed at an advanced age. The median age at cancer diagnosis in the US is 67. And so most of the patients we will be working with in terms of this malnutrition effort will be older patients. Next slide. Aging, as we know, is a heterogeneous process. And in fact, as we get older, we see huge diversity in people's age in terms of function that doesn't always reflect their chronological age. And we all hope that we're the individual at the top of the screen, water skiing at age 90, and able to ambulate freely in any environment. But we need to think about the heterogeneity of aging as we work with different patients and as we think about malnutrition. Next slide. The outcomes in these older adults with cancer can be highly variable, right? At diagnosis, they come in with a certain level of functionality and nutritional status that we then subject them to the various cancer treatments. And those outcomes can be highly influenced by their nutritional state and their functional state when they come in. Next slide, please. So one of the main things that has been going on in the geriatric oncology area is to really push for routine assessment of older adults with cancer in terms of their functionality and their ability to withstand treatment. And part of these geriatric assessments includes an assessment of malnutrition, which for most patients is a matter of just looking at change in body weight or BMI. So it's clearly not as sophisticated or as detailed as our more validated instruments such as the SGA. Assessing older adults with cancer in terms of their functionality is a clinical challenge. Chronological age and performance status alone is really not sufficient. And really, we need to be more consistent, even in this area, in terms of standardizing practice and using validated approaches. Next slide, please. So how are older adults being evaluated? And this was an ASCO Older Adults Task Force survey that was done just a couple of years ago, looking first asking, do you assess older patients differently than your younger patients? Only less than 2% said never. Clearly, clinicians realize that there could be differential approaches with older adults, that they may have a different risk profile. Many oncologists obviously think about age and functionality in terms of developing a treatment plan. And so you can see that is the majority opinion. What do you assess? Well, in terms of a formal geriatric assessment, only about 30% are using that. Most are applying more informal methods, and they report things like, well, I check to see what's going on with their body weight and whether they've lost weight. I might look to see, were they able to get up from a chair comfortably in my office? What was their walking speed as they came back to my office? So it's more informal analysis, but they are considering these factors. Next slide, please. So when we think about the geriatric oncology iceberg, yes, we have age and performance status and tumor characteristics and organ function that all inform on the care of this older patient population. Next slide, please. But under the water, there are other important information that influences the care decisions, including polypharmacy, comorbidities, recent falls or history of falls, the psychosocial dysfunction, social support, functional deficits, cognition, sarcopenia, and then nutritional deficits as well. Next slide, please. So the prevalence of malnutrition in older adults with cancer is anywhere from 15 to 73%. And it varies greatly depending on the study population, as we've heard earlier, the cancer type, the stage, and even geography. Nutritional assessment, there are many different measures that have been applied in this population. And again, like we've seen earlier, very similar issues with the heterogeneity in approaches that may be undertaken. Next slide, please. So nutrition-related symptoms in older adults also vary. In this cross-sectional analysis that was done by Dr. Williams and his team, they looked at over 3,000 cancer patients over age 60 at the University of Alabama. 52% showed us signs of malnutrition, and many of them carried high symptom burdens ranging, some were as low as 5 or 10%, but many of them were in the 20 to 30% of patient range. Next slide, please. Now, Dr. Zhang has contributed to a large body of evidence on malnutrition in aging cancer patients and in aging broadly. And in this 2019 systematic review, he looked at 10 studies, 4,700 older adults with cancer, and malnutrition was associated with about a 73% greater all-cause mortality. So in a systematic review that he published in 2017, he also identified factors such as change in BNI, albumin, hemoglobin, cholesterol, prealbumin, as other indicators of malnutrition in this older cancer patient population. Next slide, please. Now, Dr. Williams, in this 2020 paper in Cancer, also looked at consequences of malnutrition in older adults. And, basically looking at those who are malnourished versus those who are nourished, he showed that almost every one of these symptoms was worsened in the setting of malnutrition, including the quality of life, both physical health score and mental health score, which were markedly impacted by malnutrition. Next slide, please. Now, Dr. Fried has developed a phenotype that is hypothesized to drive frailty in older adults, which is highly relevant to the cancer patient population. And so I just share with you from this Journal of Gerontology article published many years ago, this interplay between weight loss, weakness in terms of grip strength, exhaustion, gait speed, and low physical activity, all of which are affecting sarcopenia. But importantly, chronic undernutrition is driving this very significantly. Next slide, please. And in fact, this interplay of sarcopenia, cachexia, and frailty make the older cancer patient population extremely vulnerable. And malnutrition is interplayed with every single one of these factors. Next slide, please. And, basically the definition of sarcopenia, frailty, and cachexia have not all been consensus driven, but overall there's similarities and some differences. But in general, malnutrition influences all of these: muscle mass, fat mass, metabolic rate, inflammation, body weight, etc. Next slide. Now, there are many interventions that have been used in older adults with cancer. They tend to be multifactorial interventions and multifaceted, and it's important that they be so, right? When we think about the nutrition component of some of these interventions, yes, they could address weight loss or body mass index change or problems with eating or feeding, but most of us would agree that to optimize the impact of our medical nutrition therapy, it's important that we, as described by our Australia colleague, think about all these other components and the professionals that can help to support these components, such as physical activity, polypharmacy, cognitive function, and function overall. Next slide, please. In this review by Dr. Mohili, this was a cluster randomized trial of 718 patients who were over the age of 70, and the average age was 77, and they did either a geriatric assessment and intervention to address problems that came out of that geriatric assessment, or as compared to usual care. And while the intervention was not associated with improvements in nutrition, you can see 60% versus 62%, what this suggests to me is that additional management strategies for the nutrition component of the geriatric assessment are likely needed, and that this may indicate the role for the registered dietitian to really change the nutritional impact and the nutritional care of these patients and improve their outcomes. Next slide, please. In this study, they also looked at the geriatric assessment intervention in terms of reducing severity of chemotoxicity interventions or chemotoxicities overall. And you can see that the geriatric assessment intervention group in blue did benefit from about a 36% reduction in chemotherapy toxicities. Unfortunately, they didn't report specifically on malnutrition in this study. Next slide, please. There also was a systematic review that I mentioned earlier that basically identified additional gaps in tailored nutrition advice for this older population. Next slide, please. So in summary, there's a high prevalence of malnutrition in older adults with cancer, and coming into a cancer diagnosis with malnutrition or developing malnutrition during therapy likely impacts survival, but we don't have a large body of evidence yet. Malnutrition is highly intertwined with sarcopenia and frailty, which also drive these outcomes. Interventions hold promise and are of interest, but often we need to address the need for multimodal and relevant outcome measures that will impact care, including cost of care, as mentioned earlier. Next slide, please. His key recommendations are that as older adults represent the majority of those diagnosed with cancer, nutritional intervention studies should consider the older adult in their design and include relevant endpoints. Prospective studies are needed to attempt to disentangle malnutrition, sarcopenia, frailty, and cachexia. Next slide, please.
That's it.
We're at the end. Thank you all.
Thank you. Thank you for that great information, Dr. Thompson. Okay, so Dr. Michael Pollack will now give a talk on studies of nutrition interventions related to cancer. Introducing Dr. Pollack, you may now begin.
Thank you very much, and I'd like to thank also all the organizers. I'm going to, in my talk, give a biological perspective on nutritional interventions in cancer treatment. I have no conflicts to disclose. And I'd like to highlight the fact that despite more than a century of research, there still are major knowledge gaps regarding nutrition and cancer risk and prevention. That's one playing field. And cancer treatment. That's another playing field. And I believe that if we're honest with ourselves, we have to admit that in large part, advice is often given to patients based on beliefs or customs rather than on rigorous scientific evidence. Now, in my charge, I was told that today's symposium is mainly confined to part B, which is nutrition in the context of cancer treatment rather than prevention. And so we're going to emphasize nutrition in the area of cancer treatment. So when we consider diet and cancer treatment, or nutrition and cancer treatment, there can be two goals of the interventions. And I'm afraid to report to you that many researchers are working in one or another of two silos. Many of us are primarily concerned with efforts to meet or exceed nutritional requirements of the host. We're concerned about cachexia. We're concerned about weight loss. And that leads to many kinds of studies and interventions that we've heard a lot about in this symposium. But also in this symposium, we've heard about evidence that actually some dietary interventions should primarily be undertaken to engineer nutritional stress for the cancer. That is, to deprive the cancer of nutrients that it requires to grow. And these two perspectives are in conflict with each other. There is an area of research which I'll tell you about and which Dr. Longo has already mentioned earlier in the symposium, which actually feels that the role of future dietary interventions may involve restrictions rather than efforts to ensure adequate nutrition. So there is actually a major scientific gap in knowledge, and it's not that we have a basic understanding of this field and we just need to fill in the details. Rather, we still lack a basic understanding of the fundamental principles of how to optimize nutritional interventions for cancer patients. And in all this work, we have to carefully consider cause and effect and distinguish association from causality. We know for sure that weight loss is associated with poor outcome. We don't necessarily have the same confidence that preventing weight loss, even if it was achievable, would improve cancer outcome. So let's consider some further background here. Dietary interventions designed to prevent weight loss or to meet or exceed nutritional requirements of the host are largely based on fear of cachexia and knowledge that advancing cancer is often associated with decreased caloric and protein intake. There is, however, a paucity of rigorous evidence that increasing nutrition intake is an effective component of cancer treatment. Even total parental nutrition has been shown in many studies to fail to improve length or quality of life in patients with cancer cachexia. Here is some data from one of these studies, which actually compared various outcome measures from a group of patients with advanced cancer cachexia that were either offered total parental nutrition or not. And without going into the details, unfortunately, the study concluded no benefit to total parental nutrition, which some might regard as the ultimate effort to ensure adequate nutrition to patients with advanced cancer. So to put it in lay terms, is it possible that optimizing nutrition is actually feeding the cancer more than benefiting the patient? So to explore this area this complex area of nutrition optimization for cancer patients, we have to consider, micronutrients, we have to consider macronutrients, and we have to recognize that there's no way to partition nutrients to selectively nourish the host as compared to the cancer. And there's a interdisciplinary effort that's needed to really understand how to optimize nutrition involving endocrinology, oncology, nutrition, and metabolism. Right, so we all know that obesity increases the risk and also worsens the prognosis of certain cancers, and 13 of them are listed in this often shown slide. Let's consider now, bearing that in mind, dietary interventions associated with the other perspective. Use diets to cause nutritional stress for cancers to impede their growth. Is it possible that restricting certain nutrients could contribute to cancer treatment success? I'd just like to remind you, as a practicing medical oncologist, that some effective and commonly used cancer treatments involve drugs that reduce the availability of micronutrients to cancer cells. For example, L-asparaginase reduces the availability of the amino acid asparagine. Antifolates restrict the availability of folates. So common cancer treatments actually have some benefit, and the mechanism of some of those treatments is actually to cause nutritional stress for cancer cells. So let's take a perspective here and ask this question. Do cancer cells really care about the host nutrition? Do cancer cells care if the host that they are living in is hungry? And you can see here the big range of differences between the McDonald's client, an obese child, starving children in an African context, and wonder whether the differences in whole organism nutrition really are related to differences at the cellular level in cellular energy balance. So it's often said that host energy balance, the host nutritional status, can directly influence the bioavailability of nutrients, for example, glucose, for cancer cells, and that variation can lead to altered proliferation. Even though that assumption is often made, laboratory studies suggest it's not the whole story. In fact, host energy balance alters the hormonal environment or the endocrine environment of the patients, for example, by influencing insulin levels. And it's those nutritionally controlled hormones that actually result in altered proliferation. So let's just review this idea. Dietary energy supply influences the growth of some tumors by influencing the hormonal environment rather than the energy available to the tumor. The effect of macronutrient intake on cancer biology involves another example of, or another context of, hormonal dependency of neoplastic cells. And it puts the spotlight on those hormones that are nutritionally regulated that can influence carcinogenesis or cancer prevention. So are there hormones that both influence cancer behavior and are regulated by your diet? What's the intersection here? Those hormones that influence cancer in blue, those hormones that are influenced by diet or obesity in yellow, and the green overlap defines those hormones that we should be interested in. And of course, as mentioned by some prior speakers, one of the most obvious candidate hormones to examine is insulin. And in fact, when the insulin receptor was first described by Alex Ulrich in 1985, they put right in the title of the Nature paper that the insulin receptor, in a molecular sense, had similarities to an oncogene. So it's not silly to actually consider the model whereby insulin levels could be a determinant of cancer behavior. All the endocrinologists traditionally study insulin receptors on adipose tissue or on other tissues like muscle or liver that are involved in regulation of blood glucose. But cancer cells also have insulin receptors. And when the insulin receptor on a cancer cell is triggered, the cancer cell often grows more aggressively. So you can see here the dietitians all will recognize how the different kinds of diets can have different effects on insulin levels, and they vary throughout the day. And the higher, the more food energy you have, the bigger the insulin secretion. And we're all used to thinking that the main action of insulin is to tell storage tissues like adipose tissue, if you see a lot of insulin, it means there's a lot of glucose in your blood, so absorb the glucose and store it as fat for a time in the future when that energy might be needed. But if you're a cancer cell, you still recognize the insulin, but you have no capacity to store glucose as fat. When a cancer cell sees an insulin level that's high, it interprets the high insulin level as it's okay to take up glucose, to use that energy in the glucose to proliferate, not to store. So if we look at some of our prior studies here, and this is an example in prostate cancer, let's look, this is, a study where it's all prostate cancer patients. It's not a risk study. It's a prognosis study. Years after diagnosis is shown on the x-axis. The probability of dying of prostate cancer is shown on the vertical axis. And you can see that if you actually are obese, you have roughly a prognosis that's double the risk of mortality, all other variables being controlled for. Double the risk. So if you have a prostate cancer, you'd rather have a low BMI. Remember, high BMIs are generally associated with high levels of insulin. And here we see data from the same study, but here we are substituting, instead of showing the BMI, we're showing the fourth quartile in red or the first quartile in green of insulin levels. So the low insulin subpopulation has a better outcome than the high insulin population, strongly suggesting that a mediator of the adverse effect of high BMI on prostate cancer outcome may be, at least in part, insulin. When we look at caloric restriction to treat cancer, as discussed by Dr. Walter Longo earlier in this symposium, we should bear in mind the long history of research in this area. This paper, which is almost 100 years old, is worth looking at. Mice are given a carcinogen, and we look for the appearance of cancers. The amount of food in grams, and this is an old crude study, just the amount of food, varies between 2.3 and 4 grams per day. And if you look at the appearance of the tumors, you can see that the calorically restricted animals have far fewer cancers than the animals that are allowed to feed ad lib. Very thought-provoking. It gives rise to the hypothesis that maybe caloric restriction could benefit some patients. It gives rise to some quackery where some patients are actually trying to calorically restrict to control their cancers. But this is an area where we have huge gaps in knowledge. To my knowledge, there's no clinical evidence to support caloric restriction to treat advanced cancers. I would repeat, no such evidence, despite the laboratory evidence to the contrary, as shown in this classic paper. I'd like to close by dealing with a research frontier. The notion that diet may influence efficacy of other cancer treatments, even if diet itself is not, that is to say, caloric restriction, is not going to be a modality for helping cancer patients. I'm going to show two examples. One is this paper from the group of Lois Cantley, which shows that a new class of drug called PI3 kinase inhibitors, the efficacy of such drugs in laboratory studies varies according to the diet that the patients are taking. If you look at the graph, it's a very simple concept to understand. The control is the blue line, the tumors grow. The red is a ketogenic diet, the tumors grow. The green is the cancer therapy, the PI3 kinase inhibitor. The cancers are somewhat inhibited. But when you combine the ketogenic diet with the drug, you get obviously the best result. A second example is actually a slide from Walter Longo that was presented earlier in this symposium, but I believe it bears repeating because the results are so dramatic. It's a similar concept. Obviously, the tumor growth is maximally suppressed in the pink line. The pink line represents fasting mimicking diet, which I can describe in more detail in the question period if you want, combined with certain hormonal treatments for breast cancer. The other lines are various controls that show that with no treatment in black or with some of the treatments in the other colors, you get some benefit. But again, by combining these treatments with a certain diet, the drugs work best. And it's not a small difference. So to wrap up my, my remarks, I'd like to comment on knowledge gaps. There are many reasonable questions with implications for everyday practice that do need to be addressed. What is the relationship between treatment success and the levels of nutritionally regulated hormones? Often cancer patients receive infusions of dextrose, which raises their insulin levels. Should this be questioned? And what about our patients? And I hear this all the time as a medical oncologist. The simple question, the common sense question, doctor, what should I eat while I'm on chemotherapy? It's embarrassing, but we really don't have good answers to these questions. And I think that we must not kind of skirt around those areas where we have gaps of knowledge. We have to shine a light on the areas where, even if it's embarrassing, we do not yet have the best answers. We don't have rigorous scientific answers. So in terms of summarizing, there's no clear evidence that dietary supplementation or restrictions significantly influences the behavior of advanced cancer. We understand fully that weight loss is associated with bad cancers and early death. But if you take such a patient and you give them TPN or force feed them, there really is much less clarity that that will improve their outcome. So an association does not necessarily mean cause and effect. The influence of diet on efficacy of treatments represents a new and active research frontier. And dietary factors in the context of cancer risk reduction represent an entirely separate important topic distinct from the effect of diet on cancer treatment. And I really haven't had time to review that today. Key recommendations: we have to increase the emphasis and funding for clinical and preclinical research on diet-drug interactions in cancer treatment. We also have to get more rigorous data to justify making a case for dietitian availability to our cancer patients. I have no doubt that in the future, dietitians will play a greater role in the everyday treatment of our cancer patients. The dietitians will be the frontline team members who deliver the best dietary advice to the cancer patients. No question about that. But I have to say, as a scientist, we do not yet know what message the dietitians should give to the cancer patients. We do not yet know the optimum nutritional strategies for our cancer patients. And in that light, I would say that my second recommendation is that we should convene an international interdisciplinary working group of experts to accelerate research in this area so that we can have a firm scientific basis for dietary advice. And obviously, it's my feeling that the gaps of knowledge in this area are huge. So I'd like to thank you for your attention.
Thank you. Hold on, I'm holding my notes. Sorry. Thank you, Dr. Pollock, for that presentation on studies of nutrition interventions related to cancer. We will now take a 5-minute break to prepare for the remaining part of today's workshop. To help keep us on time, there will be a countdown clock on the screen. We ask that you please return so we may begin on time with our last speaker for this key question, followed by the discussion and Q&A session. Thank you.
Hi, Hillary. We're at break. And then when we return, you will be the next speaker.
Okay, great. Thanks.
All right. And it says here that you want to advance your own slides. So I'll make you presenter at that point.
Yeah, I just tested it and I'm already able to do it.
It looks like you're able to do it from your screen, but you're actually not advancing slides for the audience. So I have to make you presenter first in order for that to appear.
Okay, I'll just
Okay.
accept it when I see that.
Awesome. Thank you.
This is a brief audio check for participants that have adjusted their audio settings. Just a quick audio check for participants that have adjusted their settings. Thank you.
I think I'm good. I just talked to Keisha.
Fantastic, we're set.
Okay, welcome back, everyone. Good afternoon. Let's dive right back into our workshop agenda. Next is Dr. Seligman, who will present food insecurity and cancer care. Following her presentation, we will have a discussion session for these key questions. You may begin, Dr. Seligman.
Well, thank you very much, and thank you for the opportunity to talk to you today. We're going to focus out, take a bigger picture lens today, and I think try to understand a little bit what we can learn from what's going on in other sectors, particularly around food insecurity. I do not have any disclosures. I want to acknowledge that a lot of my thinking on this topic came from a series of meetings that created a manuscript that's currently in press at JNCI called Food Insecurity Among People with Cancer, Meeting Nutritional Needs as an Essential Component of Care. I am very indebted to all of these co-authors for all of their opinions and expertise on this topic, much of which is incorporated in the next slides. I want to start us off by level setting that in 2020, about 1 in 10, 1 in 9 US households experienced food insecurity. This number has been relatively stable for decades, since the beginning of food insecurity measurement in the 1980s. And it includes households with low food security, about 6.6% of US households, for whom the quality of the diet has decreased in order to meet a very low food budget, but for whom the quantity of food in general has not had to be sacrificed. And another 3.9% of the US population experiencing very low food security, where both the quantity and the quality of food has suffered because of the need to meet a very low food budget. Many of the interventions we're going to discuss today focus on quality of diet and improving quality of diet, in addition sometimes to improving quantity of diet. As we set off on this brief journey together, I want to remind us that food insecurity often is overlapping with other social comorbidities, including housing insecurity, lack of transportation, underinsurance, access to paid leave, inflexible work hours. We can go on, and you can see the slide. This is to say that when we help patients to address food insecurity, and we do it in isolation, we are often not solving, or we are always not solving, all of the problems that are related to food insecurity. At the same time, the people at highest risk of food insecurity are people with diabetes, disability, cardiovascular disease, and other medical comorbidities, which means that patients with cancer and food insecurity are often the most vulnerable in terms of access to diet and the implications of a poor diet for their long-term health outcomes, not just in the space of cancer care. Now, this emphasis on quality has pushed a reckoning around the term food insecurity. Food security is defined by the USDA, I'm switching now to food security, as access by all people at all times to enough food for an active, healthy life. And the conversation around food security has shifted a little bit in recent years towards nutrition security. And I'm sorry, in recent months. This is quite recent. And nutrition security really elevates the importance of diet quality in the context of food security and frames it within a very explicit health equity lens. And so one shorthand that we can use today to think about food security and nutrition security, although it's not precisely accurate, is that food security is having enough calories, and this harkens back to Dr. Pollack's talk just before the break, whereas nutrition security is really focused on having the right calories. In terms of food insecurity among cancer patients, the prevalence of food insecurity in cancer populations is very heterogeneous depending on which population you choose. But in published studies seems to range from about 17 to 55%, all of which is much higher than the general population, which I told you previously was between 10 and 12% depending on what year. What we do know is that food insecurity risk factors among cancer patients tend to mirror the risk factors for food insecurity in the general population. So females are at higher risk, Latino, Hispanic, and Black households, Indigenous households, younger people, unemployed people, and people obviously with lower household incomes. Food insecurity has behavioral and social consequences relevant to cancer care, and these outcomes that are associated with food insecurity include adherence to therapy, cognitive capacity for complex decision-making, and access to survivorship and self-care resources, all of which are found to be more limited in the context of food insecurity. And in addition, food insecurity is linked to the mental health symptoms that are often commonly experienced during cancer treatment, including stress, anxiety, depression, and suicidality. In the context of this and the other presentations that are made today, I just want to state clearly that we think that food insecurity has an impact on downstream health outcomes of all types through three mechanisms. One is through dietary quality, and we're going to talk a lot about that today. But the other two are through behavioral pathways, as I allude to here, and also through inflammatory pathways, which you've heard a lot about today. So the relationships between food insecurity and downstream poor health outcomes has resulted in this conceptual framework that I like to call screen and intervene, where the hypothesis is that if we can screen patients for food insecurity in the clinical setting and identify those patients, we might be able to refer them to somebody who can manage a connection to a federal or community program. So we're stepping out now of the TPN type therapy and stepping towards therapy to improve dietary quality and potentially quantity among patients who don't have a severe disease. The referral might result in enrollment in a federal or community food program that would improve diet quality, food security, and clinical satisfaction, and ultimately improve health and utilization outcomes. What we have found is those two boxes in bold, the referral and the connection to those community-based or federal nutrition programs, are the most difficult links in this chain. So starting with this first box among identification of food insecurity, there is a very well-validated, well-disseminated, and commonly used two-item clinical screening tool called the Hunger Vital Sign. I usually preface these questions by saying, I ask all of my patients about access to food. I want to make sure that you have all the resources that are available to you to help prevent and manage disease. And then I ask these questions, and that's because these questions can be stigmatizing, and particularly for households with children, there can be a misunderstanding, or there is a myth that often has a kernel of truth to it, that if you divulge food insecurity or difficulty accessing food, that the children may be taken away from the family under a diagnosis of neglect. A response of often true or sometimes true to either of these two hunger vital sign questions on the screen suggests food insecurity and should be treated as such. In the context of cancer treatment, really the finer points we need to put on this is that cancer treatment itself often causes financial strain, and we know that that financial strain can worsen food insecurity or even create food insecurity in a household for which it did not previously exist. And we know that that food insecurity can make it difficult to afford specific food items, particularly food items that are more expensive. And this decreased capacity to choose food items may become particularly important in the context of cancer because many symptoms of cancer treatment, loss of appetite, changes in olfaction and taste, nausea and vomiting, diarrhea, difficulty chewing and swallowing, these can be partially relieved with dietary changes, many of which put increased pressure on the food budget. So in the context of this, I want to introduce a general phrase, which is a food as medicine intervention. And we can object to whether the phrase food as medicine is correct, but this is the name of a series of interventions that have become very commonly talked about in healthcare settings. And we define a food as medicine intervention as the integration of a specific food and nutrition intervention in or in close collaboration with the healthcare system. And I give you some examples that we'll go into in more detail on the next slide. These interventions are often targeted towards individuals with or at high risk for a serious health condition. And people with cancer and HIV were the first real recipients of these interventions, which we go back and think about as food as medicine interventions. They often, if not always, prioritize people with or at high risk of food insecurity. So I generally bucket these interventions into three types: the on-site programs, the community programs, and then federal nutrition programs, which are not technically food as medicine interventions, but they can be considered food as medicine interventions if the clinical referral for that nutrition program, such as SNAP, the Supplemental Nutrition Assistance Program, formerly known as food stamps, if that referral is coming from the food bank. Excuse me, it's coming from the clinical system, coming from cancer care. So let me dig into a few of these programs, and I'm going to start by saying one of the challenges we have in the food as medicine field is that access to food and the needs of cancer patients in particular are dynamic. They change over time, and the intervention that might be appropriate for a patient one week may not be appropriate for the patient's level of care the next week. And what we have particular difficulty doing is moving patients between these levels of food access as their needs change. For example, from medically tailored food for someone at risk for acute or chronic illness, for example, someone doing very well with their cancer treatment, who doesn't need help with shopping, doesn't need help with cooking or preparing food, but may actually need that support later down the line for a brief period of time associated, for example, with chemotherapy. So let me start by talking about SNAP. SNAP is a state-administered program using predominantly federal funds. This is the formerly called the food stamp program. Eligibility is generally for low-income households, and benefits are redeemable for any foods, with some exceptions for prepared foods. There is very strong evidence that SNAP improves health outcomes, reduces medication non-adherence, and reduces healthcare expenditures, although I'm not aware of any studies that look at this specifically for the cancer population. WIC is for pregnant and postpartum mothers and children up to the age of 5 who are also low income and at nutritional risk. Because WIC requires a prescription or a referral from the healthcare provider, it in and of itself meets the definition of a food as medicine intervention. And there is strong evidence now that WIC can improve dietary intake and birth outcomes and improve child academic performance, but again, no outcomes that I am aware of related to cancer treatment. Medically tailored meals are very familiar, I think, to everybody in this audience. There's relatively strong evidence now that these interventions can reduce hospital admissions and readmissions and lower medical costs, and also improve medication adherence, particularly for patients with heart failure and diabetes. But we know that these are also suitable for populations with the highest burden of disability and illness and come at a relatively high cost. And so medically tailored groceries have really been put on the table as a way to lower costs for patients who need a little bit less support with preparation of food. And these are essentially raw ingredients, again, healthy ingredients that can be assembled into meals at home and provided to patients at a lower cost. There is very little health impact data on these programs, but many people think that they will work similarly to other food as medicine interventions because they do reduce food insecurity and support healthier dietary intake. Produce prescription programs are rapidly expanding across the country, and these are programs in which a voucher for fruits and vegetables generally is provided through the healthcare system. There is lots of heterogeneity across programs and a robust area of research going on right now to understand their impact. There is rapidly building evidence that these interventions can also improve dietary intake and food security, and modeling studies show substantial downstream impacts on health impacts and healthcare costs, again, not yet specifically in cancer patients, although many of these programs have been implemented in cancer settings. And then finally, on-site food distribution has been piloted, including in a number of cancer care settings. And these might look like food pantries permanently located at hospitals or clinics. They may look like mobile food distributions that come on a weekly or monthly basis to the hospital or clinic, or they may be take-home meals provided at discharge to support patients in the week or two when they're most highly vulnerable. On-site programs have also included embedding on-site SNAP enrollment eligibility workers in the clinical setting to assist with on-site enrollment. And again, limited evaluation of data is available here, but it is really starting to accumulate. All of this can be done in the context of the National Academy of Sciences framework, the 5 A's framework for social care, that includes the importance of increasing awareness of food insecurity by screening, adjusting care models to address food insecurity, supporting referrals into food as medicine interventions, partnering with local organizations that have expertise in food distribution so we can align the goals of our healthcare system with the goals of these community-based organizations that are experts in food security and dietary intake. And finally, supporting advocacy efforts that can get at root causes, for example, insurance coverage for nutrition support and expanding paid leave during cancer treatment so that the increased risk of food insecurity that happens during cancer treatment might be mitigated. I will quickly just tell you some knowledge and policy gaps and then some recommendations. We have very limited data on the impact of food security interventions, specifically on cancer outcomes and quality of life. We don't know the most feasible and effective strategies for scaling these interventions into clinical care settings, including NCI-designated cancer centers. We need to balance scaling with the need for food programs to be culturally sensitive and responsive to the local food environment. And we have much pressure externally to make these programs cost effective. Most of the programs that are implemented to date are sustained through philanthropic investments, and that makes their sustainability limited. The priority populations, which sometimes include cancer patients, often change. And a lot of calls for insurance or health systems to start reimbursing for these services so that they can be provided more broadly. So my key recommendations are to implement standardized workflows for screening patients with cancer for food insecurity during treatment, documenting it in the electronic medical record, and then linking patients to services to support food security. There have been calls to add a food insecurity assessment to the All of Us research program so we can finally have the prospective longitudinal data we need to better understand the impact of food insecurity on cancer outcomes. We need to support the training of providers and staff in nutrition education and how it can be tailored to patients who are experiencing food insecurity. Incentivize healthcare partnerships with community organizations because these community organizations are experts in supporting the nutritional needs of people experiencing food insecurity. And finally, we need healthcare systems in particular to educate policymakers in the importance of nutrition assistance, especially SNAP, for people with cancer undergoing treatment who are struggling to afford food, and in particular, high quality and nutritious food. Thank you very much. I look forward to your questions.
Thank you, Dr. Salica. Thanks for that very insightful presentation on food insecurity and cancer care. So at this time, we would like to invite all of the speakers for this key question to join the discussion session. Thank you all for submitting questions and comments in the chat pods sent to everyone. We will continue receiving the questions throughout the discussion session. Dr. Hyatt, thank you for moderating this session. You may begin.
Yeah, wow, there's been a lot of good material to cover here, and I'm sure there's lots of questions. I've seen many of them in the chat. Let me start with one for Dr. Pollack. But wait a minute, I'm not supposed to do that. Panelists, do you have any questions for the speakers? Let's get your input first.
Heather
We're
Gold.
shy, panelists.
Hi, Heather Gold.
Heather, please.
Yes, when we talk about all the limited evidence and then we talk about multi-component interventions, I wonder how we're supposed to disentangle the effects of the little pieces of a pie that become a grand intervention if we aren't testing all the unique pieces separately. And yet we may know there are interactions between all the components of a multi-component intervention. I kind of keep leaning to these methodologic questions, but I'm wondering if folks have any thoughts, any of the panelists have any thoughts about takeaway when we're still trying to generate high quality evidence of effectiveness.
Well, I would just comment that, I think, yes, there's a need to drive the nutrition data and evidence. But in reality, the goal is to improve the health of our patients, right? And if that means combination and multifaceted interventions, that's what it means. If exercise and diet, like in the Anecto efforts that are moving forward, are more effective, then that's what we should be doing. And so I think it comes down to kind of the reductionist approach versus really looking at what might be best and where the evidence is leading us in terms of improved outcomes.
And if I could just comment, I think that if we look at pharmacotherapy, if we look at drugs, no drug company or no doctor or no patient would ask a question about a broad-based question about what drugs should we use for cancer. It has to be broken down into more specific, answerable questions. Even though we want the big picture, we can never learn about in one step, the big optimum total systems approach for optimizing diet. It's just too multifaceted. So that is the goal. But I don't think there's a shortcut. I don't think that we can evaluate a global approach. It's just unimaginably complex. So sadly, we have to go by answerable questions and test more specific, limited hypotheses where we can get an answer. If we get an answer that favors an intervention and justifies it, then we get traction for funding and we can build on that. But I'm shocked taking an overview that we see leading scientific journals talking about caloric restriction and pseudo fasting as really promising approaches, and simultaneously we see efforts to optimize how much we feed patients. This doesn't mean that one is right and one is wrong. It just shows that we have to really pay attention to context. Maybe there's situations where the dietitian really has to encourage better food intake. And yet there's another context where, in combination with a certain drug, patients should eat less or make sure that there's no glucose in their infusions. So, if the reality is complex, sadly, we can't look for simple global solutions. We have to ask tractable questions.
Any other comments from the panel on this important question? Seeing none, let's move on to some other questions from the panel.
I'm wondering if I could follow up on Dr. Pollack's suggestion that we seem to have this dichotomy. Are there certain types, to start moving this field forward, are there certain types of cancer that might be more prone to benefit from one kind of going down one fork in the road compared to those where we're looking at decreasing lean body mass loss and cachexia?
Well, again, I think this is what's remarkable to me is how important the questions are and how little we know. It's one thing to know something little about something that's unimportant, but we know very little about something that's key. And I see, even though I'm intrigued by the animal data that shows that caloric restriction restricts the growth of cancers, we really have no clinical evidence that that happens. And frankly, I don't think that I'm not tempted as a medical oncologist to try to starve my cancer patients with a therapy modality. I think the physiology underlying the animal models has to be understood, and that might give rise to some specific contexts. And I was quite impressed, and this is a trend that has been ongoing now for maybe 20 or 24 months, this notion of specific dietary restrictions actually influencing the efficacy of specific cancer drugs. And the physiology of some of that is known, involving insulin or other mediators. So, and there are some clinical trials ongoing now, combining PI3 kinase inhibitors with specific diets that lower insulin level. But I do not want to be misunderstood. I have the greatest respect for the head and neck dietary interventions where people are undergoing difficult radiation therapy, influencing their ability to swallow, and the role of the dietitians in that context to make sure that the patients get adequate nutrition. That's really important too. And I am convinced, for the dietitians in the audience, they will be the soldiers that will deliver the optimum dietary interventions to the patients. So I'm confident in that. I'm just excited about the fact that, crazy as it may sound, one day they might go into this patient's room and tell them, you have to eat more. And in the other context, they might go to the next patient and say, we're going to give you this drug. And while you're on this drug, you better avoid eating these foods, or you better make sure your caloric intake is low. So I actually think that much as I love implementation research, I actually feel that we're not quite ready in most contexts for implementation research in the field of cancer nutrition, because we're not certain enough about what we want to implement, because we don't have the evidence, except for those specific things, like in the case of head and neck cancer patients who are malnourished to begin with and have therapies that further threaten that. Okay, we know what to do there. It's more calories. In the case of PI3 kinase inhibitors, we might want to decrease carbohydrate intake. So we have little niches where we have specific questions, but we don't have a universal approach. And I don't think we ever will.
So just to follow up on that, are you suggesting, Dr. Pollock, that as we fill these research gaps, that means that rather than focusing on specific types of cancer, that the division may be focusing on categorizing evidence based on different types of treatment as well?
Yeah, I think those things are not mutually exclusive. I think that there may be opportunities for dietary. The latest research, which is kind of like, I want to emphasize as a scientist, this is kind of like Walter Longau's work and others like him. It's, you never trust just the work of one scientist, no matter how good he may be. But there's momentum now from several highly respected laboratories that these drug diet interactions, there's something going on there, and it's new. And so, we may have specific interventions where our dietitians will have jobs that are unfamiliar and yet very important. And then but the idea that we have to just sort of say, you know what, cachexia, it happens in my institution. Cachexia is bad. Give all the cancer patients Ensure. Just eat as much as you can. That's probably a false generalization where it may even be neutral or possibly even harmful. So it's all going to be a case, I think, of precision. It's going to be precision dietetics. The way we don't have one drug that we give all cancer patients, and I don't think we're going to have one diet that we give all cancer patients.
Excellent. Other comments or questions from our panel?
I would just add that not only are we not going to have one diet, it's probably going to change throughout the treatment continuum, and need to be reevaluated along the way for precision.
Yes, I agree with that too. And it was beyond my scope, but there may be some more generally applicable principles for cancer risk reduction that are broadly applicable for population science. Like when it comes to, to use a silly example, we don't have to spend too much time customizing advice to avoid tobacco. Probably everybody should. And there's certain dietary principles for prevention that may be broadly applicable. The trouble with the prevention trials, whether it's prevention, interventions that involve drugs or diet, prevention research is really tough because the endpoints, you have to sit around. It's like more than an academic career. Like if you're talking in diet, it's probably a lot what happens, especially breast cancer. It's probably a lot what you eat around menarche. So like if you want to look at effect of diet around menarche to cancer rates at age 50 in a prevention context, a single career is not long enough to carry out that study. So it's by definition, the prevention endpoints are very, very tough because of the lengths of time. So I don't have a solution for that. Maybe surrogate markers could help a little bit. But when it comes to the treatment, that's where I think it's going to be like almost like what's good for one patient may be counterproductive for another.
Okay. I want to ask a question. Dr. Parsons has mentioned a couple times that there's no conceptual framework in this field. What would a conceptual framework look like? Because we have variability in the interventions, we have variability in the cancer sites, we have variability in the outcomes, we have variability over time. So are we talking about some sort of complicated causal diagram, or what exactly would a effective contextual framework look like? Dr. Parsons, do you have a thought on that?
Well, I will just say that I'll look to experts in the nutrition field for this, but I would say, you know, to move forward, I think it could be very useful in order to identify within a contextual framework. I mean, you you hit it on the head. You don't want it to be overly complex. You need it to be thoughtful in terms of what it's including, but at the same time, if we want to think about where are the biggest opportunities to have the biggest impact. And if you think about the interventions and maybe some of the interventions that have been studied, you know, trying to, you know, introduce a nutrition diet for, you know, 2 days, or when somebody's just an inpatient, is that going to really have a long-term impact conceptually on their overall survival or their some of the primary outcomes that you're interested in? I mean, I think that that's a real question. So what, again, maybe getting back to some of Heather's comments, you know, what are those trial designs that you could think about it, that would allow for some of those types of questions to be asked and be adaptive and thinking about all of the different components that might go into it, and then using that as a framework for where you intervene and where you focus the resources and the funding. So that's just kind of a starting point. I'm very curious to hear what the other experts have to say.
I think Deborah has a thought. No, I thought you were raising your hand there. You're not, you don't have you're muted, so.
Apologies, I'm still, yeah.
Okay, now I can hear you. Were you raising your hand?
No, I was not.
Okay, all right, thank you. Okay, Dr. Clayton, please.
So building on your comment about modeling, I was interested in Dr. Thompson's, I believe, comments about a call to disentangle the linkages between frailty, sarcopenia, and cachexia. But given what we've heard over 2 days of a lack of concise definitions, lack of biomarkers, and the multitude of contextual variables, seems to me we're nowhere near the ability to be able to untangle these. And it begs the question, how would you draw a model with this? Would you use these as mediators, as moderators of outcomes? I'd be interested in your thoughts, because I'm not convinced the science is there to allow us to untangle cachexia, sarcopenia, frailty, especially in an elder population with comorbids. Another mediator or moderator.
So that was part of Dr. Williams' presentation, so I don't want to try and fully interpret what he was thinking, but I do think he was trying to acknowledge that there is this interplay, and perhaps thinking back to the multifaceted components, that if we address only malnutrition and don't think about all these other factors that influence malnutrition, that we may not get too far ahead. I think that was his take home. But I agree. I mean, I think a conceptual model would be helpful for us, thinking back to that comment, in that we could have a better understanding, as Dr. Parsons mentioned, of the factors that are influencing the malnutrition, as well as the key outcomes that we need to start addressing. And I do think that conceptual models help people in designing their research in a way that really has more meaning, even though I feel like right now a conceptual model will be, very dynamic and changing. And we are unlikely to be able to address all of the factors that have moved forward today, but I do feel like it would at least give us a starting place to begin to be a little more systematic about this.
Thank you for that. I think that's myself. I think that's the correct approach. Um,
Now I do have a comment.
okay,
So,
please, Dr. Collins.
okay.
Just to follow up on the idea of a model, since we've heard multiple times that the average American diet, and especially someone before even the time of diagnosis with cancer, has a poor quality diet by most standards of dietary patterns. If we're trying to do build a model for a study to see the advantage of some of these interventions, what would be the value of, instead of using current standard of care, which doesn't address, we're still leaving the control group with poor diet quality, to have as the control group, just trying to provide baseline, maybe advice comparable to what we advise for reducing risk of cancer, versus an intervention that goes further down a particular track? Or do we need to have standard of care, often meaning nothing, as our control in these studies?
Any thoughts about that point?
Well, I actually would submit that we want to, as in any study, you want to give yourself a chance by maximizing the difference between the control group and the intervention group. Dietary factors may not have huge effect sizes. They may still have very important effect sizes, but they may not be huge. So I would think that standard of care as a control group makes sense as long as the standard of care is well defined, because of the fact that we've heard at the meeting deservedly that the standards can vary. So if we for example would say a junk food diet is the standard of care, we'd have to sort of say, well, this is what we mean by a junk food diet, and make sure that the control groups all take something like that. I mean, if the institutional review boards would not think it's unethical, but then you would actually have an intervention group where you might maximize the differences, if there are differences. But again, I just want to make the comment, which is that everything to do with prevention, which is possibly where we'll have the biggest impact, is methodologically difficult, because no one would think that a short-term dietary intervention will have any effect on cancer risk or cancer incidence. The question is, like, are we talking 1 decade or 2 decades? If the endpoint is cancer risk. The advantage of studying cancer dietary effects on cancer treatment success, even though it's very, very difficult in many ways, the endpoints the timelines are much shorter, right? The cancer treatment will be successful or not in less than a year. So that's why dietary interventions in the context of modifying treatment success are in some ways more practical. But I think that it has to be a more sophisticated, specific question is going to actually be easier to answer. Like, I wouldn't make a hypothesis like of this type, that giving supplements to cancer patients will make them live longer. Or if you're on the other side, dietary restrictions to cancer patients will enhance treatment success. These are far too general hypotheses. It's like saying, will cancer treatment with drugs help? You have to sort of say a much more specific, tractable question, like some of them have been asked already and answered, like, If I have a patient who can't swallow because they're getting radiation therapy and I give them tube feedings through their stomach in that particular context, what will the outcome, how much will the outcome improve? And maybe you'll have another one where if I give a PI3 kinase inhibitor coupled with a low carb diet, maybe I can answer that question if it's better than the drug alone, with a study involving 50 patients in each group. And these are very specific questions that are tractable. And I would get away from the much more general questions where one might just get, you might have a null study because there's just too many uncontrolled variables.
So as your chair, I want to point out we have 10 minutes left for questions and discussions. Dr. Witzwaller, I see your hand is up.
Yeah, I do have my
Collins
hand
and
up
Dr.
now.
Pollock, your hand is up too. I don't know if you want to set.
No, I put my hand down.
Okay.
Yeah,
Deborah.
I'll try to put my hand down. I can't tell if I'm up or down. So thank you. And now I do have a comment trying to, I guess, reconcile some of the comments that have come from Dr. Thompson, Dr. Pollock, and even integrating what we heard yesterday, and especially back to the idea of a conceptual model in an attempt to try to find some sort of pathway forward on our sets of recommendations or sets of summarization. But can we come up with a conceptual model for the cancer patient, not prevention of cancer, but for the cancer patient that can somehow address the, I don't want to say conflicting messages, but at least different messages about when we need supplements, whether it's TPN, parental enteral, whatnot, versus what we heard from Dr. Longo and others about I forget what the acronym is, FMD and other sort of caloric restrictions, where a conceptual model might, identify where and for whom, where the evidence is there, where it's not, and for whom this would work. And then back to the endpoint. I mean, we saw the figure yesterday. Where are all the phase 1, 2, 3 trials within the cancer sphere, and for what cancer site? And very concentrated over there on lung cancer and non-small cell lung cancer because the endpoints are so close and so well defined, where we can come up with statistically significant outcome variables with a 5 to 11 week differential. I'm not saying we go there, but we come up in a conceptual model. What are metrics that seem to have at least some sort of recognition as a optimal improvement of an endpoint X? And maybe that's whether you complete treatment, maybe it's changes of body weights, but be able to come up with an array of what those endpoints are. Because right now I feel like we have like what's that diagram where you have a bunch of words all coming in that have been said a bunch of times, but we're not having a pattern that's going a particular direction. So I keep trying to make up myself before Dr. Thompson, before you came up with the term, we need a conceptual model. I was trying to I was trying to draw out direct and indirect pathways, and my arrows are getting too convoluted to even make sense. So I'll stop talking.
We'll have some opportunity to work on that after the conference, Deborah. But I think it's a fruitful area to put some more thought into. Let me reassure all of you who have put such good questions in the chat that these are all being captured, and if any of the panelists or speakers can answer them directly for the participants, that would be excellent. If they can't, we'll incorporate them into our assessment after the seminar, after the conference. So a couple of other questions from the audience. As I scroll here through the comments, of which there are many. System of food banks and food pantries. This is for you, Dr. Sigelman. Is the system of food banks? Oh no, this is you answering. Sorry. Okay, scrolling up further. Dr. Pollack, you've highlighted the point that we need more nutritional research in general, and we need to assess tailored approaches to oncology and nutritional recommendations. I don't believe anybody working in oncology nutrition has a one-size-fits-all approach, but I do try to meet patients where they are. So I agree with the total parental nutrition comments, generally not recommended except for very few instances where oral enteral nutrition aren't possible. I think you've responded to that. You've commented on that. I think that's another oncologist, sharing their experience. Here's one though. Is the reason why patients with advanced cancer and severe cachexia are not benefiting from total parenteral nutrition is because their nutritional status is already so compromised and cancer so advanced?
Actually, I believe that that's not the case. I think that it's a question of association versus causality. I think you have a bad cancer that's gonna you've got a bad cancer that's going to be associated with a very poor prognosis, and it also causes weight loss. But you cannot assume that reversing the weight loss will make the cancer less aggressive. So I think that using weight loss in a cachexic patient with an advanced cancer as a kind of biomarker for a bad cancer is kind of true, but you can't say that if I attach the patient to an IV and feed them lipids, amino acids, and glucose, and even if I could get the weight back up, I don't think the prognosis of the cancer would improve. It's like true and unrelated. The cancer is causing weight loss. The weight loss is affecting quality of life, no question about it. But the problem is the cancer, and the weight loss is if we can't cure the cancer by dealing with the weight loss. I think that's a little naive, and it's sad. We would be doing so much TPN if total parental nutrition would actually help cancer patients. It would be a huge business. But the fact is that the data really are quite convincing that it's like just like when we treat pain, we can make the pain go away, but the cancer doesn't get better. And we can make even if we could make the weight loss go away, I don't think it's going to influence the prognosis. Without belittling the association of weight loss with outcome, I think I've beaten that one to death. But we see it all the time, and I think that the problem of cachexia is very difficult, and we have to treat the cause of the cachexia, not just try to treat cachexia by supplementing the diet.
Thank you. All right. I think we have time for one more. Dr. Sigelman, is there, and let me point out that the Olive study, by the way, does have questions in it that are the hunger questions, the two that you mentioned. So you've got 500,000 people already answering that question with a big, long runway in front of them. I'm glad to talk to you about that later.
Hey, Bob, I love that you're about to ask me a question, but I wonder if I might answer Heidi's question or comment that she just put in the chat box.
Okay, good.
If I have
Go
the
ahead,
floor.
please.
It's an excellent question about whether we need to do different nutrition studies on all different types of cancers. And I just want to highlight that in some of these particularly federal nutrition programs that are very broadly scaled, there are about 49 million people enrolled in SNAP every year. With good data analysis that's well connected with health records, we should be able to look at cancer populations very broadly and not necessarily have to start in these subpopulations of cancer patients. So I think we should be leveraging that data, and a critical area for future work is to try to have better connections between these data sources that allow us to do these population-wide studies.
Great. Well, I think this has been wonderful. A lot of food for thought, so to speak. And we're not starved, nor are we insecure in the information we've gathered this afternoon. So I want to thank everybody on the panel side as well as the speakers, and turn it back over to Keisha for final comments.
Well, thanks, Dr. Hyatt, and to the panelists and speakers for this quite engaging and informative session. So how is everyone feeling after completing 2 days of the workshop? Well, I'm feeling kind of excited and more knowledgeable. I hope you're looking forward to our third and final workshop day tomorrow. So I'm just going to go over a few things before I'll let you all go. Next slide. So if we can keep going. Thanks, Catherine. To slide 12. All righty. So first of all, I want to remind everyone that the EPC draft systematic evidence review is live and available for public review and comment until August 23rd. You can access that via the ODP webpage link provided in the chat, prevention.nih.gov / nutrition cancer health. So we would love to hear from you about how today's workshop went. Please remember, next slide, Catherine. Please remember to complete our post-workshop evaluation survey. The survey is different for each day. We're going to put a survey link in the chat pod, and each attendee will also receive an email from the WebEx reminding you of the survey. It should take only 5 to 10 minutes to complete, so we hope that we hear from you, as your comments will definitely help ODP improve the P2P program. Before we end, next slide, I'd like to cover what to expect tomorrow. We ask that you please join us by 11:55 a.m. Eastern Time so that we may begin promptly at 12 p.m. Eastern Time. We will cover key questions 4 and the contextual question, and also hold a lightning recap among all the speakers and hear final words from the NIH co-sponsors. So if you have already registered for day 3, you should have already received a reminder, including the workshop link. If you're not registered for day 3 and would like to join us, you can register at prevention.nih.gov / nutrition cancer health. If you have any questions about the workshop from today, a registration question or a technical question, please send an email to nihp2p@mail.nih.gov. Thank you all for an excellent day. We hope to see you tomorrow at 11:55 Eastern Time. Enjoy the rest of your day.
Thank you very much.
Thank you.
Thank you very much.